depletion of T3, and periphery you will get a low T3. So the tissues will have metabolic symptoms of low T3, but TSH will be suppressed to the normal range. So you can get deficiency with T3 effect through that pathway. So that is why people are highlighting on the deiodinase 2 pathway. That's the one issue. Regarding LT3 treatment, the problem is that even psychiatrists use leothyroxine as an antidepressant because of its effect on the neurotransmitter level. So we don't know whether as a euthyroid patient, there are trials that shows that leothyroxine has got a good antidepressant. It's a difficult area to really draw conclusion unless you have a specific parameter to measure this. When you do give LT3, this will be the effect of LT3 in it. So that is why we have challenges on it. So I think it's still a disputed area. Still, it's going to be a disputed area for decades.
And one more thing, in our trial, where we used once-weekly thyroxine therapy, there was no increase in the T3 levels post-treatment.
Yeah, that's the reason for this explanation is this one.
Even at 2 hours.
Yeah, actually, that leads to suppression of T3. That is why people are not using T4 to T3 ratio in patients who are on levothyroxine. That is why we need another marker. So when you're using T4, actually periphery T3 get suppressed and you get a low T3, and TSH still may be normal range. So that delay is the issue, and that is why we need better markers.
My point is regarding the cardiac issue.
Effects.
The
cardiac. But the problem is that there are trials in patients who are removed complete thyroid, and if your patient is exclusive on levothyroxine for long term, they are telling that even T4 can have a end organ effect just like T3. So direct effect can happen with high doses. So there are a lot of things we don't know. That may be the answer to that. Thank you.
And even the pulse rate was not changed.
One request from the organizers: those who are attending online, please raise your hand to ask a question. Pradosh, I have a question. Should we start doing more when we were on patients on replacement? Should we start monitoring T3, T4, and TSH as a? Generally, we do only a TSH nowadays. Most of the patients are monitoring. So, will it help? Some basic question.
If the patient achieved normal TSH and still symptomatic, it's better to do thyroid function in full, because if you get a low T3, you have to think about this entity. It can be due to many other factors, because low T3 can be part of NTA spectrum. Even psychiatric illness can overlap, chronic fatigue syndrome. So there are a lot of differential you need to exclude. Just going to the diagnosis of probably T3 insufficiency. That is why I often feel that unless you don't have a definite tissue level marker for T3 effect, it's very difficult going to be difficult in practice, and it's a challenge.
I think the message is that we all the textbooks suggest that we monitor therapy with TSH alone. I also personally feel that is not correct, because nowadays you know that TSH is being altered by so many other drugs like metformin and all those things. And the second thing is there is no harm in doing a T4 and TSH together, so that at least you can know the slightly lower TSH is not due to the excess dose or not, because we can't be 100% sure with our lab assays. 2 assays going wrong are going to be wrong is less chance rather than 1. That is why I always insist on doing T4 and TSH. Come on.
Sir, I have one question about that Thypro questionnaire. I was searching for a questionnaire to see it in our routine clinical practice. Which one do you suggest? Is there an abbreviated form of Thypro questionnaire available?
They told that they have around 89 questions. I don't exactly remember, and they have a shorter version of 34. But it's the best.
Is it validated in our population? It
may not be validated because it's a new questionnaire. I have to say that, and it's a recent recommendation. So probably we need studies to validate it.
I think the questionnaire-based studies are good for publications. If you want to improve your number of publications, that is the best thing. I think in the day-to-day management of cases, this questionnaire based on, in my experience during the last so many years, not only in endocrinology, in all the fields, questionnaire is good for making papers.
Pradosh, one question. Would it would be a good idea for PACE to do a T3 TSH ratio or something like that? Is there some study looking at the T3 TSH ratio? I suppose that's a simple thing to do.
Yes,
T3 levels and TSH, some sort of relation, some sort of regression equation can be derived based on their improvement in the quality of life. You know,
Yeah.
you put all those values, it may not be a ratio, it may be something slightly complex also, some regression
Few
equation.
things they mentioned that the T3 T4 ratio. One thing is the assay issues with the free T3, and second thing is the half-life of levothyroxine. If you're using levothyroxine, it's short-acting
No,
preparation.
I'm talking about patients who are not on
already. Yeah,
94 only.
definitely.
94 only.
Definitely. We can consider that because levothyroxine, as we already explained, can lead to lowering of T3 and normalization of higher T4. So the ratio might be a good thing to do, because if you have baseline thing and follow, if it is altering, then we can postulate something out of it with the questionnaire collaborating with it.
I think
She's already planning that.
I think Amrita can undertake it, and I think Indian Thyroid Society has got money to give also. They are asking for research grant. So one of these, I think, PACE group can take up. I think Harish can initiate the study from Amrita.
Yeah, Pradosh, thanks for the excellent presentation. So there are some studies which says that the persistent symptoms are different in different type of etiologies of hypothyroidism, and it was said that even the post-radioactive iodine or post-thyroidectomy hypothyroidism, the symptoms are lesser when compared to autoimmune hypothyroidism. And they postulate that autoimmunity, there are some autoimmunity may be the reason for the persistence of symptoms. Your comments and
Actually, there is one slide, because lack of time, I just skipped that. Thing is that I already showed that slide. I think a patient who is not happy on LT3, LT4 combined therapy, what they're postulating is it may be due to autoimmune etiology of hypothyroidism. That is a well-regarded concept, and the studies are ongoing. And we know that antibodies is a controversial area, but still it's a concept that is ongoing, and antibodies can lead to symptoms. That is what they're telling. Maybe subclinical cortisol deficiency or some other organ damage. We don't know why antibodies. It's just a corroborative evidence. So it may be one thought process going on, and we may need further research on that.
So I think we will wind up the session.
Dr. Pradosh, can I ask you a question?
Thank you for the presentation, and
Dr. Pradosh.
Thank you, chairpersons and speakers, for the wonderful discussion and the excellent presentation. Now we'll go on to the next session, that is on liquid biopsy in thyroid cancer. Have we arrived? So for this, I invite Dr. Abhilash Nair. Sir is the Assistant Professor, Department of Endocrinology, Government Medical College, Trivandrum. We also have Dr. V. Shashikumar, sir. Sir will be joining us online.
Okay, can you hear me?
Yes, sir.
Okay. Next, we have a very, very recent topic, probably belonging to the oncology field, and we are in the picture because thyroid malignancies are the most common adult malignancies we are facing. Liquid biopsy is a technique by which the circulating tumor cells, circulating DNA, exosomes, exosomal microRNA are all studied by NGS or the digital PCR, and the various abnormalities like single point SNPs and single point mutations are studied. And you make a conclusion not only from the diagnostic point of view, but also from the treatment point of view, immunotherapy especially. And probably the most important aspect of this is the residual tumor management. That's where the thyroid malignancies come in the picture. This is a very recent topic, probably evolved in the last 10 or 15 years, and considered to be one of the quantum leap measures in the treatment of malignancies as a whole. To take on this topic, we have Dr. Tushan Thomas. I request Dr. Abhilash to introduce the speaker.
The topic already sir has introduced. Tushan sir is very well known to all of us here. He's a leading practitioner at Trivandrum. He's from, he has my senior at All India Institute of Medical Sciences, and he has many publications and many presentations to his credit. Sir, please.
Good morning, dear friends. At the outset, let me thank Harish sir, Nisha Madam and Praveen sir for having invited me. So the topic for me is liquid thyroid biopsy. Have we arrived? So basically what it means is looking at some biochemical markers in the serum in patients with malignancy. It is much more established in other malignancies. In thyroid, the data is evolving. I will try to go through the data whichever is available, because as you all know, the practical knowledge in this aspect is pretty nil. More of theoretical knowledge when I went through the articles. And anybody has any personal experience in using this, we can discuss it at the end of my presentation. So to introduce the topic, what are the limitations of the present ways of monitoring in thyroid malignancies? So in current practice, the surveillance for thyroid cancer recurrence relies on certain biomarkers and on radiological assessment. And the biomarkers are usually thyroglobulin and calcitonin levels, and the radiological tests are ultrasound, then PET-CT. These are usual methods. Though these are the gold standard, all of these modalities have some limitations. That is why the new things have come up. So what are the limitations of these tumor markers? Like the poorly differentiated thyroid carcinomas, sorry, it's PDTC, poorly differentiated thyroid carcinomas. Now, they usually express TG in a very low concentration only. So up to around 15% of patients with metastasis, they might have TG levels which are less than 1 microgram only. And these low TG levels are seen more in patients who have tumors with aggressive histology and with the BRAF mutations. And anti-thyroglobulin level antibodies can interfere with the thyroglobulin assay. So that again can be one interference. And in patients who have intact thyroid, like somebody who has undergone only hemithyroidectomy or a lobectomy, in that scenario, the utility of thyroglobulin would be less. And in case of medullary thyroid carcinoma, usually calcitonin we use, but calcitonin also has some other limitations that it can be elevated in patients with renal failure, sepsis. So some other conditions it can be elevated. And then coming to the radiological part, ultrasound is often limited. The ultrasound has limitations. It may not have the ability to differentiate, even if there's a minimal tissue in the thyroid bed, whether it is really a malignant tissue. It would be difficult to differentiate based on a routine ultrasound. And repeated CTs or PET-CTs, it will incur more radiation to the patient, and that may trigger a second malignancy to the patient. So that is regarding follow-up of a patient with non-thyroid malignancy. Coming to a indeterminate nodule, like a patient who has a nodule in which the biopsy comes as a atypia of undetermined significance, or follicular neoplasm or follicular lesion of undetermined significance. So Bethesda 3 and 4 categories, they pose a challenge. These are the indeterminate nodules. So at this juncture, we are many times stuck upon like what to do, whether to send the patient for surgery or not. So some of the available options are review the ultrasound once again, see whether there is any evidence of high risk. You can go for a second opinion. And nowadays there are recommendations to go for the molecular assays also. So if the molecular assays show a suspicious or high risk type of genetics for the patient, then it's better to go for surgery. But this is not routinely available for us, going for all these molecular techniques. These are the recommended ones. They look the gene expression classifier, then next generation sequencing, microRNAs. All these are various molecular methods to look. They assess around the number like 167 genes, They look for so many mutations and whether the patient has a genetic makeup which is at high risk for thyroid malignancy. That is what they are looking at. And if a patient has such a high risk malignancy, high risk in the genetic analysis, it's better to send them for surgery. So that is what the molecular studies would recommend. So based on these recommendations, in a patient with indeterminate nodule, you can go for the next generation sequencing. And if that's molecular analysis shows a suspicious genetic makeup of the patient, it's better to send the patient for surgery. But that again requires tissue. This genetic analysis is done in the FNA. Whatever tissue is taken, it's from that tissue that they do. So if the initial sample is not preserved, it requires one more sampling. So that again is another procedure. So the demerits are like one, it is expensive, not easily available, not feasible in a resource poor setting, and requirement of collection of FNA samples further because you require the tissue. And it's another invasive process. So if you compare liquid biopsy, which is going for these tests in a serum or in fluids, as compared to FNA, FNA is invasive. Unless you preserve it, repeated testing may not be possible. Whereas in liquid biopsy, it is minimally invasive, a short procedure only. More complete information can be available and you can repeat the test. Like if one test you did not get the adequate result, you can repeat it. And during follow-up also it can be repeated. How many to see the response to treatment, we can repeat it. So because of these shortcomings, there comes the need for new screening tools. Because thyroid malignancies, many times, they express some mutations. These mutations are mostly in, like almost 70% of the mutations are in the RAS, BRAF, or in the RET. So many times, 70% of these patients would have mutations in these genes. So what is liquid biopsy? Liquid biopsy is sampling and analysis of blood or other body tissues for informative biomarkers. So what are the components which are studied in this? They look at the circulating tumor cells, circulating free nucleic acids, which include both DNA and RNA, as well as microRNA, and also tumor-derived extracellular vesicles. And these are released into the bloodstream, and these can be detected and analyzed. That is what is done in liquid biopsy. And it is shown to be a powerful tool in several other malignancies, especially in lung malignancy. It is when I discussed with one of the oncology friends, they have started using it in lung malignancy mainly. So it's more used in lung, colorectal cancers and in breast cancers. And in recent years, there has been an increase in the literature assessing the role of liquid biopsies in thyroid cancer also. So it can be used for diagnosis, to predict tumor prognosis, monitor the disease evolution, as well as to establish pharmacological approaches, like certain mutations would predict the response to tyrosine kinase inhibitors. So whether that mutation is present or not, that can be assessed. So this is what is done. So from a peripheral blood sample, it is centrifuged, and from the plasma, DNA and RNA are extracted. This is using either real-time PCR technique or digital droplet PCR, that is ddPCR. And finally, next generation sequencing also can be done to screen for unknown mutations. So this is the way in which liquid biopsies are done, usually done in blood, but they are told that it can be done in other bodily fluids also. So circulating free DNA, then circulating tumor cells, CTC is circulating tumor cells, then extravascular vesicles. So most commonly studied things are CTC, that is circulating tumor cells, and much more commonly studied is cfDNA, circulating free DNA, and microRNA also some data is there. Advantages of liquid biopsy would be because it's a simple test, easy to perform, non-invasive, repeated tests can be done. So cell-free DNA, they are double stranded and highly fragmented DNA particles, around 150 base pair in length, and they are present outside the cells in the body fluids. It is present in the blood as well as in other body fluids like urine, saliva, CSF, breast milk, amniotic fluid. So normally there would be a very minimal concentration. It originates from leukocytes, but in presence of a malignancy, excessive DNA released by apoptosis, necrosis, and active cellular secretion can lead on to high concentration of cell-free DNA in the circulation. And it has a short half-life, 16 minutes to 2 hours. So it provides very dynamic tool for tracking treatment response. Like once you demonstrate a high concentration, you can look at the concentration post-therapy and see the response to that. So it can be used in the screening, detection, diagnosis, staging, prognosis, and as well as for monitoring therapy. And it can be used to detect specific mutations also. Like in case of thyroid, we can look at the BRAF mutation from the cell-free DNA. So the liquid biopsy in thyroid, it usually detects these specific mutations like the BRAF or the RET mutations. These are the most commonly studied mutations because these are the most commonly associated tumor mutations in malignancies. BRAF in differentiated thyroid CAs. RET also is seen in around 40% of patients with a PTC. And RET, as we all know, more commonly associated with the MTC also, medullary thyroid carcinoma. So in all of these conditions, like differentiated thyroid carcinoma, poorly differentiated thyroid carcinoma, or anaplastic thyroid carcinoma, as well as in MTC, there is data on the usage of all of these components, but more commonly with the cfDNA. That is what is more commonly studied. So several studies are there, but different studies are used different protocols. So this is some summary slides on various studies. So in most of these studies, they have looked at the BRAF and the RET mutations. And in some of the studies, there have been a concordance with the extent of the disease, but it is not uniformly seen. Like in some studies, there has not been any concordance which is reported. So as you can see, like this is concordance of the circulating tumor DNA to the tissue. Tissue means from the, like if they are undergone the surgery from the biopsy tissue. So like concordance is 0% in one or two of the studies, 42, 6%, in another study, 100%, 67%, 90%. So concordance rate varies. And it can be used for prognostic purpose also, like for diagnosis as well as for prognosis. Like the presence of mutations usually predicts the response to treatment. Like higher concentrations means that they would be a poor responder to radioactive iodine treatment. And certain mutations, as I told previously, it's an indication for starting tyrosine kinase inhibitor. And if new mutations appear during follow-up, like they can do it repeatedly, new mutations, some of these mutations might predict resistance to therapy. Like somebody initially responded to tyrosine kinase, but subsequently they show disease progression. That mutation, some new mutations can also be detected in this. The new mutations may predict resistance to therapy also. So in diagnostic applications, the main problem is non-concordance between the tissue sampling and the liquid biopsy results. And monitoring treatment purpose also, it is usually done, the levels, whether it comes down with treatment, and more for predicting the response, as I told in the previous slide, whether it will respond to radioactive iodine therapy or we need to go for tyrosine kinase inhibitor. And because tyrosine kinase inhibitor, we need to be careful because it is associated with significant drug toxicity. So we cannot blindly start it in all the patients. So in patients who are showing the probable mutations, which are most probably suggesting tumor response to that tyrosine kinase inhibitor, in such patients only, we need to go for this. Then in anaplastic thyroid carcinoma also, it has been studied. And in this, actually, the concordance is better in anaplastic. That means in more poorly differentiated tumors, actually, the concordance of the mutations is better. In anaplastic, you can see that most of these studies, it has shown concordance with mutations retrieved in tumor tissues. And if mutations are present, it usually indicates worse overall survival. And based on the therapeutic decisions also can be made. Like if you detect a BRAF mutation, it is an indication for tyrosine kinase inhibitor therapy. So that is the usage in anaplastic thyroid carcinoma. And in MTC also, it has been used, medullary thyroid carcinoma, for diagnosis as well as for prognostic and therapeutic purposes, it has been used. Epigenetic markers also, like microRNA, DNA methylation, in these aspects also it has been used, and it has been found to be very useful, especially the microRNA. Certain microRNA mutations like 222, this 146, these are the numbered mutations. They have been found to be actually predictive of malignancy. Like if you have a tissue in which it is shown to have this mutation, it is found more in patients with a thyroid malignancy as compared to a patient with a benign nodule. So in patients with the indeterminate nodule, you can go for these tests, especially microRNA is one test, but we have more data with the circulating free DNA, but microRNA also is coming up. The only problem is some limitations are there with microRNA, so it's not that much use. Now coming to one of the papers which has been published from India, Dr. Sujay Ghosh and team recently published, plasma cell-free DNA to differentiate malignant from benign thyroid nodules. They had published their work. So in this, they actually looked at the concentration of the circulating free DNA. So actually what they did was that they took around 120 patients total, and Bethesda 1 and 2 were not considered for surgery. 3, 4, 5, and 6 were considered for surgery. And in 2, if there was an indication like large size, such indication was there, that was taken up for surgery. So from 3 to 6, and in some patients in Bethesda 2, they were taken up for surgery. And in 5 and 6, we are sure it is malignancy. But in patients who had initially Bethesda 3 and 4, that is indeterminate nodules, such patients, what was the final outcome? That is what they looked. So there were 37 patients who fell into Bethesda 3 and 4. And they looked at the cell-free DNA concentration. And you can see that after surgery, those who had benign lesions, their concentration was much less as compared to malignant lesions. Actually, in this, the proportion of malignant patients is high. Like usually what we see in the studies, I think around 20 to 30% is the malignancy reported in patients with 3 and 4. But in here, you can see that almost 65% of the patients had malignancy in the final biopsy report after initial Bethesda report of 3 or 4. And patients with the malignancy had much higher cell-free DNA concentration. And they have proposed this cutoff also based on their study, based on ROC analysis. And it was found that a cell-free DNA concentration more than 67.9 nanogram, it was predictive of malignancy. That is from their study. So Bethesda 3 and Bethesda 4, 37 patients, and final 24 patients turned out to be malignant, and they had much higher cell-free DNA. And they had repeated the cell-free DNA concentration after surgery. And the patients who had malignancy in the Bethesda 3 and 4, they had a significant fall in the cell-free DNA post-surgery also. So that again is another indicator that the study, the cell-free DNA analysis was beneficial in confirming that it is a malignancy as such. And they finally did mutations also. So out of the 37 patients, 31 of the patients had mutations like BRAF, NRAS, KRAS, HRAS, RET mutations. So this was from Dr. Sujay Ghosh's paper. So the detection of dimer mutations in the cell-free DNA along with normalization of cfDNA levels following surgery in patients with differentiated thyroid cancer strongly suggests that the source of the rays of circulating from DNA in patients with cancer in these patients was indeed the thyroid tumor. And the high concentration had positive correlation with lymph node mets, lymphovascular invasion, capsular invasion, extrathyroidal invasion, tumor size, it was not significant, and with PNM staging also. So to summarize, liquid biopsy is a promising alternative during the diagnostic workup, prognostic definition, therapeutic choices, and follow-up of thyroid cancer patients. It offers several advantages. Advantages are a good number, like less invasive procedure, very few side effects, repeatability, representativeness of the tumor heterogeneity. The mutations in PTC as well as in MTC can be routinely screened through liquid biopsy to assess sensitivity towards targeted agents, like BRAF mutations are predictive of response to tyrosine kinase inhibitors, and new mutations appearing, they predict onset of resistance also. So those patients may not respond further to tyrosine kinase inhibitor. So in the era of targeted therapy, because now we have a large number of targeted therapies coming up, liquid biopsies provide a simple tool and reduce the need for invasive biopsies to gauge eligibility and monitor treatment response. Furthermore, with the increasing incidence of thyroid cancer, cost-effective and low-risk monitoring and diagnostics with high sensitivity and specificity will reduce the burden of long-term follow-up. But it has some challenges also. The main data available is small studies only, and at least in the diagnostic part, it has shown some discordance, like not in all studies, 100% concordance between the liquid biopsy results and the tumor, the tissue, the per se tissue result. It has 100% concordance is not proven, but more beneficial, especially in terms of predicting the response to treatment as well as predicting the development of resistance. That would be based on the present evidence. That is a more feasible thing which can be used for which liquid biopsy can be used. For diagnostic purpose, it has been studied. Concordance is not there. If you get a result, you can tell that. But if you don't get a result, you may not rule out also. So several challenges, mainly depending on the sensitivity and specificity of the different methods and the tumor subtype and the various tumor stages. Limitations to its widespread applicability include the low level of the circulating tumor DNA in patients with thyroid cancer. So you may not get that much, the quantity of the DNA which can be isolated may not be that much, especially in patients with early stage disease. You may not get that much quantity in the circulation. And currently, limited evidence base with small sample sizes and variable methods used to detect and report circulating tumor DNA. And improved third P deletion in liquid biopsies would aid in the prognosis, because as of now, this mutation is not routinely detected in the liquid biopsies. But if the newer methods can improve that detection, that would further help in prognostication and treatment planning. And further studies are also required on the role of epigenetic markers, because microRNA has been found to be very beneficial, but those studies also, different studies like standardization, the cutoffs used, everything have been different. So the role of circulating tumor DNA in thyroid cancer would be like in indeterminate nodules, it may help, but more beneficial in monitoring treatment as well as predicting response to a treatment, as well as in predicting treatment resistance. So to conclude, although the clinical utility of liquid biopsy is progressively consolidating over time, efforts are needed to incorporate this technology into clinical practice, as has already happened in many other tumor types like lung malignancy. Even though it is unlikely that liquid biopsy will completely substitute tissue biopsy. We have gone through some limitations, but it's unlikely that it will completely replace that. But the two techniques can be complementary. But the applications of liquid biopsy keep on broadening. There are new techniques coming up for the CTC detection, isolation, characterization. Given the rapid evolution and improvement in this field, other applications may emerge in the future for the management of the different thyroid cancer subtypes. And in this context, there are international bodies also, like European Liquid Biopsy Society and the US-based blood pact, who are working to move liquid biopsy from the bench to the bedside. Thank you.
Thank you, Dr. Tushant. Nice talking. A very, very current topic. Tushant, after hearing you, we must remember that this has not been approved for thyroid malignancies. It has been approved by FDA only for ovarian bronchial malignancies, not for thyroid malignancies. Is it right?
So the question is not very clear. Can you please repeat that?
This liquid biopsy has been recommended by FDA only for bronchial malignancies, ovarian malignancies, but not probably for thyroid malignancies. Is it right? Or
Sir, is FDA approved? Is it FDA approved for thyroid malignancies?
I don't think it's FDA approved. Whatever data I could see in the articles, these review articles are also very recently last year published. They have not mentioned that it is approved as such. It is more of a experimental type of thing. Even in oncology, they use it more for lung malignancy. That is for what they are using it more. In other malignancies also, the evidence is building up only. So for thyroid, I don't think it is FDA approved. All these data, it is evolving.
Sir, thank you very much for a very lucid talk on an issue which we usually don't come across. We are not at all accustomed to. So you had a lot of reading, must have done a lot of reading for this. And it also brings out the importance of knowing genetic, at least the basic of genetics for all clinicians. So now at present, we may be practicing without any exposure to genetics, but probably now onwards we need to have some hands-on experience on the basics, at least how to extract the DNA, what are the steps involved, or what are the basic steps in PCR, etc. So with that, if there are any questions, we can have.
Dr. Tushant, probably FNAC is a very ordinary thing for us. We do it. But this technique, if it is successful, probably it is more useful in the management of residual tumors than probably diagnosing the primary tumors. Is it not?
Yeah, that's what I told. Like if you whatever data is available, that also shows that when it has been used for the diagnostic purpose, the concordance has not been that much good. Like patients who had proven malignancy from tissue sampling, but when they repeated the same test in the for a liquid biopsy, like looking for mutations in the cell-free DNA, the concordance rate was pretty poor. In one study, actually, there 0% was the concordance. In one other study, like 4%, 6%, then 41%, another 67%, like that. So for diagnostic purpose, the concordance has been very poor, very inconsistent. So I think for diagnostic purpose, it may not be that much beneficial, but for treatment monitoring and for predicting response to treatment and resistance, I think for that aspect, it would be more beneficial. But when newer techniques come up, when the isolation techniques improve, maybe in the future it might improve. But as of now, with the available data, I think for diagnostic purpose, the evidence is still inconsistent.
Sir, Prashant sir has a question.
I mean, basic question, because of my ignorance, is cell-free DNA, is it specific for thyroid? If you have two cancers at a time, two malignancies, one a non-thyroid malignancy, will this CFDA cell-free DNA go up? Or is it specific? Because the mutation might be specific.
Yeah, mutation will be specific. Like if you look at the concentration, like in Dr. Sujay study, they had looked at the but finally they did the mutation also. But the concentration had fallen down after surgery. Concentration had fallen down. So if you look at the quantitative cfDNA, I think it can indicate any malignancy. But if you look at specifically the mutation or post-therapy, like you did something for the thyroid malignancy and it is coming down, like after surgery or after ablation, it is coming down, then it would be indicative of the thyroid malignancy. Otherwise, the quantity per se will be indicative of any malignancy.
But cell-free DNA and circulating tumor DNA, they are two different things. Cell-free DNA may be present in autoimmune diseases, chronic inflammation. It's a non-specific thing. ctDNA probably is the specific thing. But this study, particular study you have shown, that's again on cell-free DNA. There is some
These-
lack
Yeah,
of
I think
clarity
both,
on
I
that.
think both the terminologies are used. I think more or less
Sir, I
interchangeable.
think sir is telling out the CT, which is a circulating
CT.
tumor cells.
Yeah,
Tumor DNA, the other is circulating free
in,
DNA.
in the articles you will see like CFDNA is also there, CTDNA is there. CFDNA is
Yeah.
cell-free DNA, and CTDNA is circulating tumor
cells.
DNA.
Yeah.
But many a times they have used it interchangeably. I think more or less interchangeable.
Sir, any updates from Amrita whether we are putting our hands on these things?
Doing cell-free DNA technology is not very difficult, but I think we have not embarked on such a study. But I think Sujay's study was mind-boggling because just a cell-free DNA, I don't think I would have ever thought that just a cell-free DNA, because in most of the other tumors, it never had this very remarkable. Look at the sensitivity and specificity is close to 100%. So it's kind of mind-boggling. So
Yeah,
it's the best when compared to. I think we can correct me in the chance. None of the other malignancies have shown this sort of high results.
Yeah, this Dr. Sujay's results in that study, it was very good, like the sensitivity and prediction.
While supporting an Indian article, we should also keep in mind that the sample size was 37 and the margins of errors are at least we didn't see now. We could go into the depth of the paper. But the margins of errors should also be kept in mind.
That's all there, but still, as an initial study,
Definitely.
it looks very promising. Yeah.
I had read a bit about around that, so I thought maybe I can clarify a little. Cell-free DNA, whenever there's large-scale tissue damage itself, cell-free DNA will go up, like Sir had said. So even if you have a trauma, burns, myocardial infarction, sepsis, all of these reasons, it can go up. And for the same reason, in a non-vascular tumor, where there's not much access to blood, again, cell-free DNA will not go up. So that is why lung cancers, cell-free DNA has been approved for follow-up, because there'll be tumor lysis. But thyroid, we have a highly vascular tissue.
Yeah, but then they would be just isolating only, like whether we can, like once they isolate the DNA asset, whether they can make out whether it is tumorous or not.
That was why the phase 2 of Dr. Sujay's study is very important, because they were looking for the specific genes. So just like we are following up for thyroglobulin theoretically, if the genetic data is really good, you can follow up for a cancer for that. But then the other things which you presented were very good, Dr. Sushant, about microRNA again. But I think we have to think, like, just like we know that micropapillary carcinoma is not very important. There are chronic lesions. We may have a lot of data coming in for a lot of small, not very important genetic data. It may be taking many, many years before we can use a liquid biopsy to screen the population, general population. But maybe as a follow-up, it may be useful.
Very valid comments. Sir, with the basis of this talk, I think we should also have some initiative to identify where we could do all this tests in the future from PACE. I think there should be some consensus regarding do we have to send it to a external lab, or whether we should develop a center where we can do it somewhere in Kerala. With that, I think, Shashimar sir, if there are no more comments, can we close the session?
Yeah, we can close the session. Thank you, Tushant. Thank you very much for the nice
An excellent talk by Tushant sir. Thank you.
Thank you.
So once again, thank you, chairpersons and speaker, for the enlightening talk. The next session we will be having is on tennis and AIMS experience. So for this, I invite Chairperson Dr. Sunil Menon. Sir is the Senior Consultant Endocrinologist at Sunil K. Menon Center for DM and Endocrinology. We also have Dr. Vasantha Nair. Madam is a Senior Most Endocrinologist from Kerala. Madam would be joining us online. I request the chairpersons to take over the proceedings. Thank you.
Good morning, everybody. First of all, I will congratulate the Amrita team for conducting such a wonderful session on thyroid. So today's duty, my duty is to actually introduce the topic. I think this is much more familiar than the two topics we already discussed, which we usually manage. So tennis actually that is thyroglobulin elevated with negative identity. So we do come across cases of this sort, and I think we'll also discuss the last topic, like use of liquid biopsy in these patients with tennis also, how it will be useful. So on behalf of Hasna Madam also, I am inviting Madam to deliver the talk.
Yeah, good morning to one and all. Thank you very much for the kind words, Dr. Sunil. So, can I have my slides on? Yeah. Okay, so greetings from Amrita Institute, and today I'm going to share our experience with the tennis. So I must admit that I'm actually presenting the fruits of all the hard work done by Vasanta Madam. Madam has been instrumental in starting the thyroid cancer clinic in 2010. And since then, she has been managing patients meticulously and following ATA guideline 2009, and has maintained a database of about 2,000 patients. And she has also organized the thyroid cancer clinic so well, along with all other departments which will take part in the management of a thyroid cancer patient. So I must thank all members of the team, and as well as Dr. Rupa Vijayan, who was our PG. She passed out and gone to UK. So before much delay, just go into the topic. You all know that follow-up of DTC is basically accurate surveillance for risk of recurrence using thyroglobulin, TG antibody, and iodine 131 whole body scan. But seldom we encounter a situation where the TG is elevated, but the whole body iodine scan is negative. Various studies have shown that this will amount to about 10 to 27% of these patients. And the probable reasons are like iodine sufficiency by mistake, they are not following iodine-free diet, or they have had a contrast exposure, or some iodine, sodium iodine, sodium iodine importer down regulation or a de-differentiation of the tumor. Whatever be the reason, this poses a diagnostic challenge. So basically, we know once the patient comes like that, the next thing you can do is to look at the neck with an ultrasound, which is a easy non-invasive technique. And many a time it might show some local recurrence or lymph node metastasis, and which you can manage accordingly. And sometimes you may need a CT or MRI chest of the neck. MRI is good for aerodigestive invasion and all, but CT is also very good for lung metastasis. But when the TG is very high, or you suspect that there may be more lesions, you can opt for an FTG PET CT. And then now there are many novel molecular imaging radiopharmaceuticals are coming in, which will do an immunospect and immunopet and all, but it is not available in our place. And so we'll stick with the PET CT. So basically, we cannot equate tennis with a radioiodine refractory disease because radioiodine refractoriness is defined as absence of radioiodine uptake in all lesions or in some lesions, and progression despite a radioiodine treatment and reaching maximum recommended activity of radioiodine. So tennis may be due to radioiodine refractoriness, but all radioiodine refractory patients are not tennis, because sometimes they may show up these lesions. So now when this patient comes with a negative neck ultrasound, this poses a special problem, especially in our part of the world, because there is all these expensive investigations like CT, MRI, FDG, PET, and empiric radioiodine therapy, whether we should do that or whether should follow up. All these problem comes. So actually this study which we have published is actually dealing with this population. So ATA 2015 has recommended one dose of empiric radioiodine therapy if the TG is above 10 and there is a negative imaging. but this study was done prior to that. So this data was published in the World Journal of Nuclear Medicine in December 2021. So this was done as a retrospective study of the DTC patients enrolled from 2008 to 2015. And the aim of the study was to look at the prevalence of tennis and also the ultrasound negativity in them, and also look at the other features of this group. So we used the strict inclusion criteria with a negative whole body scan and a TG level more than 1 in the stimulated state with on an iodine-free diet, and a negative neck ultrasound, negative TG antibody, and at least 3 stimulated TGs, and at least a follow-up of 2 years. And the exclusion criteria was younger patient and those who has not received a radioiodine ablation after total thyroidectomy, as they may have small amount of thyroglobulin, and other thyroid cancers and insufficient data people all were excluded. So during that time, our tennis management was based on the American Thyroid Guideline 2009, and basically they were managed looking at the initial histopathology, whether they had a high risk tumor, and the TG level, imaging studies, and also the last treatment post-therapy scan. And we used to have a regular thyroid tumor board to discuss with all other specialists, and as well as patient preference and affordability, especially in our Indian setting, patients don't have any insurance. So empirical radioiodine therapy we have been using in these patients, and usually for high-risk patients with the TG more than 10, or showing an increasing TG trend or imaging evidence of an unresectable disease. And for these patients, a negative response was considered when the post-therapy scan was negative and TG has actually increased. And positive response is when the post-therapy scan was positive or TG dropped more than 50% after 6 months to 12 months. Partial response was like post-therapy scan is negative, but TG is dropping, but not up to 50%. So additional doses were given at the time when this uptake was persisting in the post-therapy scan, or TG is falling until the TG become undetectable. But if the first therapy, empiric therapy was ineffective, no further doses were actually withheld. So all these patients who fulfill the criteria were selected from the database, and their details were collected, compiled, and analyzed. Laboratory assays were done in our own hospital, and the reference ranges are all, we followed the reference ranges specified by the lab. So the clinical endpoints were actually, as per the Tatil et al. Study, no evidence of disease when the TG is low and scanning is negative, and PBD when there is a slight amount of thyroglobulin, but there is no evidence of structural imaging, and persistent structural disease when there is some evidence of in the imaging, some evidence of residual disease. And indeterminate means the slight amount of TG and non-specific findings in ultrasound. You're not very sure whether it is malignancy or not. Recurrent diseases after the becoming no evidence of disease, they're developing disease again. So in our study base, we took patients from the database of 722, and the tennis patients were identified. There were 193 tennis patients that amount to about 26.7. And from them, ultrasound positive patients were excluded, and then there was 101. And after removing the TG antibody negative and 3 consecutive, those who have TG and at least 2-year follow-up were selected. So our study sample constituted 64 patients. So these are the baseline characteristics of these patients, and you can see here, they're not much different from the baseline database, except that they were having a little more of follicular thyroid cancer in them, and high risk was more in this tennis group. Similarly, distant metastasis as well as lymph node metastasis was higher in this group. So they probably had a more severe disease. So when did they become tennis? Usually majority of them became tennis at 6-month follow-up, And at 1 year, another 20% become tennis, and the rest all became tennis within a couple of years. So what was the TG level at the time of tennis? This was ranging from 1.2 to 996, and median value was 6.5. And when we classified them into less than 10 and more than 10, about half of them were below 10 and half of them are more than 10. And this is the distribution of TG in our patients. You can see this 2 to 10 was the maximum. And less than 2 was also a significant number was there. So we followed them up for about 7.8 years. That was our mean follow-up, and majority of them had at least 5 to 10 years of follow-up. So what happened to them after the during the follow-up? 20% patients developed a new lymph node metastasis. One thing to remember here that 12 of them are again picked up by ultrasound. So this emphasized the need of repeating the ultrasound, even though initially it was negative. And then the new distant metastasis was identified in 9 patients, and most of them were in the lung, and some in bone and lung, and 1 in liver, and there were about 3 deaths. So the PET was done only in 18 patients. So though there are many who actually needed PET, we could not do because of financial implications. So you can see here that many a time the findings was lymph node and distant metastasis, which was picked up by the PET. And there were 4 negative patients. And the treatment which we offered were like empiric radioiodine therapy for 16 patients, and salvage surgeries like lymph node dissection, and EBRT for 7 patients for distant mets, as well as for thyroid bed recovery. And then regarding this empiric radioiodine therapy, we have given for 16 patients. And if you look here, you can see 12 patients received 1 dose and 4 patients received more than 1 dose. And most of the indications were distant mets with the lymph node metastasis or lymph node metastasis alone, which are probably unresectable, and thyroid bed lesion for 1. And if you look here, there is 1 low risk patient who had empiric radioiodine therapy, and most of them belong to intermediate or high risk therapy. And so this outcome, what happened to them at the end of the follow-up? 51.6% become disease free, and 31.3% are remaining actually with a structural disease, and 12.5% have still have TG positive and PBD, but no structural evidence, and 4.7 are having a little indeterminate disease. The mean time to NED was about 4.1 years in this group, and it ranged from 1 to 9 years. And spontaneous normalization of TG was seen in about 27 patients. So these PSD patients, the 20 patients who had, 16 of them had distant metastasis, and 4 had a persistent lymph node metastasis. And 11 patients with the distant metastasis had progressive disease with increasing TG and worsening structural disease, and 3 actually died. So those with the PBD patients, most of them were showing a falling trend of TG. Probably they'll become NED, but there was only 1 who was showing an increase, and till now the imaging is negative. The 3 ID patients also showed a falling trend in TG. So we looked at the factors associated with a favorable outcome like NED, and unfavorable outcome is PSD plus PBD. We found that the age above 55 and a high risk tumor and TG more than 10, and the presence of distant metastasis, presence of lymph node metastasis, all these had significantly higher possibility of an unfavorable outcome. And these are actually factors which are related to the presence of distant metastasis. And this empiric radiation therapy is associated with the poor prognosis, probably because we are giving into the sicker patients. And PET scan positivity is also associated with the poor prognosis, which is a well-known fact. Whereas gender, type of tumor, and time of tennis were not significantly associated with the bad prognosis. I think I'm just. So the multivariate analysis of these factors showed only presence of distant metastasis as associated with a poor prognosis. So then we looked at the TG level, because distant metastasis is not something which is present in everybody. So that was not very helpful. So we looked at the TG level and we found that if you look at this, the less than 2 TG value, all of them become NED, whereas more than 100 TG, all of them are remaining with the persistent structural disease. Between 2 to 10 TG, 50% of them become NED and they have more PBD, whereas between 10 to 100, you can see the PSD, that is structural disease, is actually increasing. And so we try to compare the TG group, that is less than 10 versus more than 10. Here, this is the basic parameters of them. You can see the low risk people have more of TG value less than 10. Similarly, females have more of less than 10. That was not much different. So looking again at the NED, you can see the disease-free status was more in less than 10 group, and distant metastasis, lymph node metastasis, all were less in, significantly less than 10 TG group. And the survival plot showed they have actually better surveillance after actually 111 months was the survival in less than TG group compared to 72 months in the more than TG group, more than 10 TG group. And the ROC curve analysis to look at the cutoff for TG level in our population showed a value of 10.4. However, the sensitivity and specificity were actually not that great, but this is actually comparable to what suggested by ATA. Yeah, I just want you to pay a little attention here, because this is the low risk people, and you can see 11 of them belong to TG10 group, less than TG, and most of them have recovered or become disease free, and only one is PBD, and that's falling. Probably he will join the group of NED. And more than 10, the spontaneous NED, almost all of them, one is ID, they will also become NED. But this is one patient who had a persistent structural disease. I think there was some confusion in his initial risk stratification, because his TG was 120 at the 6 months. So probably if he had done it at 3 weeks after his surgery, it would have been more than 100 and he might have gone into intermediate risk. So this may be misclassification. Otherwise, you can be rest assured that in low risk category, most of the people, they do well. Whereas in intermediate risk, risk of ATA risk category, you can see this less than 10 TG. Most of them had spontaneous drop in TG, and one had a PSP, but that too, lymph node metastasis, and there were a few patients who needed a lymph node dissection. Whereas in TG more than 10, there's 6 patients actually got NED. And then they had some progressive disease when their TG values were more than 10. Similarly, in high-risk group also, there were few spontaneous drop, but still most of them had progressive disease or a structural disease. So this actually told us that probably you need to consider the risk stratification along with this TG value in deciding the follow-up of these patients and management of these patients. So this 10.4 cutoff was as per the ATR recommendation, and this is actually what we have shown is validates this suggestion. But we didn't give radioiodine to all. We considered the risk stratification as well. And the best prediction from our cohort was combining ATR risk category and the TG level. And the progression-free survival in our patients were significantly better when the TG level was less than 10. Empiric therapy was associated poor outcome in our group, probably because these patients fell in the high risk category and had a distant metastasis. And then independent effect of this could not be assessed because they also had a lymph node dissection and other EBRT, etc. So tyrosine TKA were not used much at that time because it was not available and affordable. So there were some limitations to our study because of the small sample size and we could not do PET and E-therapy and all for everybody who probably actually qualified for, but we have done meticulous inclusion criteria, so that gives us some reliability of the result. So to conclude, tennis was seen in 26.7% of our DTC cohort, and ultrasound was negative in half of them. And most common cause of tennis was lymph node mets followed by distant mets. And TG dropped spontaneously in about 42.7% of the patients. And less than 10 TG may do well if they are low or even intermediate ATA risk. If TG is more than 10, they need to be closely followed up and periodically imaged for disease progression. And distant metastasis suggests probably poor outcome, and E-therapy is not shown to be much used to them. And actually, we need larger studies to confirm these results. So what is the future? Probably this is something which Dr. Abhilash was saying. We need to learn a lot of molecular medicine now. So there are new molecular markers which are coming, which may help us in such situation in the future. But many of them are still in the pipeline and not affordable to many of our patients. But this may be actually helpful in the future. So thank you very much for your patient listening. And I thank the Thyroid Cancer Care team for making me present this year. Thank you.
Thank you, madam. Thank you, madam, for enlightening with the work going on, Amrita. And I also thank and congratulate Vasna madam also. So the topic is open for discussion.
Congrats for the excellent presentation.
Thank you.
So what's the maximum cumulative dose of radioactive iodine in your experience that is given? Maximum cumulative dose of radioactive iodine dose. And have you encountered any second malignancies due to radioactive iodine dose?
Yeah, actually, the maximum dose given which we have seen is 800 millicurie, and they are very keen. We used to have thyroid tumor board discussion, so we don't usually go beyond that. There was one patient who actually continued to have a bone metastasis, for which we have given that because she had severe increase in the lesion. But that's the maximum we have seen. And then secondary malignancies, yes, we have seen one bone marrow suppression for a patient and one leukemia in our database we have identified, but we have not systematically looked at the database for secondary malignancies. Vasanta madam, if there is any comments, please, madam.
I agree with you, Usha. Leukemia is the one disease that we found in some of our patients, so the leukemia in one patient. And we have rarely gone beyond 800. Once in a while, we are given up to 1,000, I think, because the nuclear medicine people are very enthusiastic, but rarely have we gone beyond 800.
Madam, you have a center where you have nuclear medicine also incorporated along with your center. So all the iodine scans that you're doing, you are following up 3 weeks iodine diet. Do you feel, because from personal experience, classified as tennis, and I have sent to you over to your side, then we find that most often, some situations at least, it is the poor preparation, the lack of the iodine diet, and what we thought as tennis after coming or after a repeat iodine scan turns out to be it's a normal, there is an uptake still there. So what is your experience that do you repeat all the patients who get referred to you for tennis from elsewhere with a repeat iodine scan? Is 3 weeks preparation really necessary for all patients when we are planning for stimulated TG?
Yeah, actually, these tennis patients, 3 weeks of iodine free diet is actually helpful. However, we haven't done a study to see whether they are really iodine free. Actually, we've been contemplating this for a long time, but because of the problem to get the iodine done immediately, because we cannot wait for them to have the iodine done elsewhere and get the result later, we could not do. But I think depending on all the situations, like risk category, the value of tennis, the TG value, TG antibody, presence of TG antibody, and altogether we make a call on such patients, because we may not always repeat the scan. Sometimes if the TG value is not that high, we may ask them to repeat the value after 3 months or so. So this poor preparation may be one reason for tennis. That is, of course, it's there. But in our center, the nuclear medicine people are very keen, enthusiastic, and most of the patients are coming well prepared. But it is actually an important issue, and probably need a proper study to see
I have
whether.
a comment to make, Usha. Usha, I
Yes,
have a
madam.
comment to make. See, our nuclear medicine specialist, Dr. Shanmugam, insists that we should keep them at least 3 weeks iodine-free diet, because Kerala people eat a lot of iodine, high iodine diet, and he says it takes at least 3 weeks to clear it from the circulation. So he insists on the 3 weeks, although literature, if you look at the literature, it says even 2 weeks is sufficient. But I think our diet is high in iodine, and he thinks that it takes at least 3 weeks for it to be washed out.
Thank you, ma'am.
Well, this is about that empirical iodine dose that have been given in some of those patients. You did say that there was, I think 50% was the response rate from the slides in those patients with empirical iodine. So there are some papers that say that even if you give empirical iodine, the TG may fall down initially, and subsequently over a period of time, the TG will increase again back. Did you notice that in your patients?
Yes, there are some patients like that. Initially, they may be responding, but then later on they may differentiate further and may not respond. So actually, that's why we need to follow them up carefully, and we have seen many patients like that.
Madam, just here. So, if we are using, as Dr. Tushanda discussed, if you were able to use molecular markers in those patients with high risk, maybe after 6 months, you had seen most of the patients had tennis from 6 months onwards. So from there onwards, if we are able to use the molecular markers, whether it will help in the future in the management of these patients.
You mean liquid biopsy? Yeah, I think that's something which we are very excited about. And actually, Vasudha Madam and we were thinking about doing something with that. And I think it's wonderful to have some marker like that in such patients. But we haven't been able to do that so far. But it would be really exciting to see what it shows. Let this go.
We are extremely sorry for the technical glitches. Now we'll come to the final talk of the session. This will be on evaluation of thyroid nodules, Trivandrum experience. For this, I invite Dr. Jabbar sir. Sir is the professor and head of the Department of Endocrinology, Government Medical College, Trivandrum. And I also invite Dr. Titu Uman, who's the consultant endocrinologist at Providence Endocrine and Diabetes Specialty Center, Trivandrum. I invite the chairpersons to take over the proceedings.
Good morning, everyone. So I think the time is little late now. Okay. First of all, on behalf of myself and Dr. Titu, sincere thanks to Amrita team, Harris sir and his team for the chance given to us for chairing the session. The topic is, as soon as we apparently looking very simple issue, but very, very tough issue, sometimes an extremely difficult. Even the tennis, lot of nodule sensitivity, specificity in configuration interval, all those things, lot of things are there. But for a patient point of view, average physician's point of view, it's extremely difficult to categorize the disease. Is it a malignant disease? Is it a benign disease? And we have very small experience from Trivandrum Medical College, myself, Dr. Jayagumari, Dr. Abhilash, and my sincere students team. We did a small study, and Dr. Soumya is going to discuss about this topic. I will hand over the mic to my co-chair to introduce the speaker.
At the outset, thanks to my teachers at the Amrita Department of Endocrinology for giving me this opportunity to chair the session. And also, I will welcome Dr. Soumya to the stage. She needs no introduction, I guess, to this PACE members. She's one of the young firebrand trainees who have passed out from under Dr. Jabbar sir's guidance. I mean, they all have been garnering almost all the awards in Indian endocrinology, so much that, you know, to get a DM seat under Jabbar sir's training, I think will require separate super specialty training, I guess. So Soumya is a very good, elegant speaker. I've heard her speak before, and she's going to speak us about the Trivandrum experience with regards to MNG.
Thank you, sir, for the kind introduction. Good morning, everyone. Greetings from the Department of Endocrinology, Trivandrum. I'm feeling humbled to stand in front of this august gathering today. Thank you organizers for giving me this opportunity. And I pay my respects to my chairpersons, Dr. Jabbar sir, who is my beloved teacher and mentor, and Titu sir, who is a well-known figure in the field of endocrinology. Today, I'm going to share a few points which we have learned from evaluation of thyroid nodule and a brief review of literature on what we have what we have learned on reviewing the literature. Let us start with a simple exercise. Can you find the hidden 8 in this pattern of 9s? Time up. I hope you can relate it to the search for malignancy in a thyroid nodule. 9s are so common here that if you start looking for 8 in every 9, you will find more 8s, and the clinical significance of which you don't know. On the contrary, if you miss this 8, there are high chances that your doctor next door will surely find this out and your career is doomed. So with that introduction, I go to my slides. There is the prevalence of nodular thyroid disease ranges from 7% on palpation to up to 76% on ultrasonography. And the average prevalence of malignancy across the world in thyroid nodules is up to 6.5%. And the estimated prevalence of malignancy, thyroid malignancy in Indian population is 0.1%. So what are the tools in our armamentarium for diagnosing a malignancy in thyroid nodule? First is ultrasound. We have different risk stratification systems based on ultrasound, namely the ATA, ACR, European TERADS, Korean TERADS, the ACE. And the second is a fine needle aspiration cytology and the Bethesda system. And the final word, whether it's malignant or benign, is by a surgery. But we can't refer everyone for surgery to find a malignancy in such a common disease. What is new in the evaluation of thyroid nodules? We've already heard some very good talks on this now. Elastography, molecular studies, contrast-enhanced ultrasound, FDG PET, and liquid biopsy, including quantitative and qualitative assessment of plasma, cell-free DNA, RNA, and microRNAs. But we are living in a part of the world where all these are not handy to us. We are left with our tools, the ultrasound and the FNAC for diagnosing malignancy. So talking about the ultrasound risk stratification systems, ATA and the ACR TERADS are the most commonly discussed ones. How can you compare this ultrasound risk stratification systems? ATA is basically a pattern recognition where you recognize a pattern and assign it to a risk category, and the risk of malignancy is assigned and an indication for FNAC is there. As you see, the estimated risk of malignancy, there is a sudden jump in the risk of malignancy from intermediate to high suspicion. So this is basically a qualitative categorization than of a quantitative one, because it's a yes or no like phenomenon, more of an yes or no phenomenon. And if you watch the cutoff criteria recommended for FNAC by the ATA, they recommend a size cutoff of up to as high as 2 centimeters for a very low suspicion nodule. That is, even a spongiform nodule more than 2 centimeters, they are advised to do a FNAC. So the sensitivity for finding a malignancy is higher for ATA. And the ACR TERADS. It was first introduced by Horvath and then revised by Quack, which came in 2011. This was the original initial previous ACR TERADS, which is now also many of the radiologists are comfortable in reporting this system nowadays, this 4x4, even after the introduction of the 2017 white paper of ACR TERADS. And in 2017, the ACR TERADS white paper came by Tesla et al. And it has been made into a more quantifiable one, where and more objective one, where points are assigned to each of the ultrasound-based characteristics and weightage points are there. You can add this up and get a TERADS score. And they also recommend size cutoff criteria. They say that FNAC is not recommended for TERADS 1 and 2. For TERADS 3, 4, and 5, they give a cutoff of 2.5 centimeters, 1.5 centimeters, and 1 centimeter. So their size cutoff criteria is slightly higher, where the ATA is more a liberal cutoff for FNAC. So when comparing this ATA and ACR TERADS, the sensitivity is a little bit higher for ATA, as we already told. And the specificity is low for all these, all ultrasound guided risk stratification systems. It is around 60% only for all the classification systems. And when you see that this number of unclassified nodules, 3.8% of the nodules on an average from different studies could not be classified by ATA, because there are certain patterns which does not fit into the tight categories of ATA. Like if you have an isoechoic nodule with the rim calcification, you can't classify it in ATA. Whereas in ACR, since it is an addition as a cumulative scoring, there are no nodules which can't be classified by ACR TERADS. That is one advantage. And comparing this, as I've already told, ATA is more of a qualitative one, whereas ACR is more of a quantitative one. And in terms of reducing the number of unnecessary biopsies, that is also an important concern when in our clinical practice. The ACR TERADS allowed the largest reduction with the lowest false negative rate in terms of that. So what are the challenges in the evaluation of thyroid nodule that we usually face? One is whom to perform FNAC. Should we follow the cutoff criteria by ATA? Should we follow it by the ACR TERADS? No, none of these guidelines recommend a FNAC for a TERADS 5 nodule, which is less than 10 millimeters. So am I confident enough to leave home a patient with TERADS 5 subcentimetric nodule? Am I missing a malignancy? That's an important concern. Second is indeterminate cytology. What should I do next? Molecular studies not available. Should I do lobectomy or follow-up? Also, what is the chance of missing a malignancy if I just follow up? Then the concern of overdiagnosis, which I'll be discussing now, and how to follow up these nodules. There have been many papers which says that the incidence of thyroid cancer is increasing worldwide to a greater magnitude than extrapolated from the previous prevalences. And it has been largely attributed to overdiagnosis. This paper was published in JCM 2020, and it includes 8 centers. It is a multicentric study from different parts of India. It includes RCC cancer registry also. That is why Thiruvananthapuram is included. And they have shown that this greater magnitude of increase in incidence of thyroid malignancy is largely due to an overdiagnosis. Maybe it is due to better access to diagnostic modalities as the years pass by. But the overdiagnosis has been defined as a detection of tumors that would be unlikely to progress to symptoms or death even if left untreated. It is not a follow-up study. They have just taken the survival values. The 5-year survival rate of thyroid malignancy on an average is 90 to 99%. So they've extrapolated that data and said that this much of malignancy diagnosis overdiagnosed. But the real overdiagnosis, when we follow up these patients and see how many of them are developing. Are there any underlying factors going on in the background radiation, our lifestyle, food, BMI? Are there any factors that is actually attributed to our increase in incidence? We don't know. We don't have papers showing that any significant correlation. So diagnosing thyroid malignancy while keeping oneself within the narrow balance between overdiagnosis and underdiagnosis is a relevant clinical concern. With that in mind, we have conducted a study. This was my thesis done under the guidance of Jabbar sir and Ablash sir. It was a prospective validation of accuracy of ACR TERADS in diagnosing malignancy in thyroid nodules and a prediction score for thyroid malignancy. We have included all thyroid nodules more than 10 millimeter. We have done ACR TERADS scoring for the thyroid nodules and taken all nodules which are more than 10 millimeter. And if the TERADS score is 4 or 5, we took all nodules more than 6 millimeter or more for FNAC. This was our size cutoff criteria. It is much lower than the one recommended by the ATA because ACR, because we wanted to check the accuracy of size cutoff criteria put forward by ACR TERADS. So consecutive patients from the OP were included, always sent to for ultrasound guided ACR TERADS scoring by a single radiologist, and inclusion criteria was applied, that is 10 millimeter for TERADS 1 to 3 nodules and 6 millimeter or more for 4 and 5 nodules. And all these nodules underwent ultrasound guided FNAC by a single person, that is principal investigator, that is myself. And the Bethesda was reported by 2 pathologists. And depending on the Bethesda, either thyroidectomy or follow-up was advised for the patients. So we included 317 nodules. And this was the Bethesda 2, 3, 4, 5, 6 breakup of those nodules. All Bethesda 4, 5, and 6 nodules went for surgery. And Bethesda 3 were given an option of follow-up, close follow-up or surgery, depending on the ultrasound characteristics and patient preference for follow-up. And those who opt thyroidectomy underwent thyroidectomy and the HPR was collected. A total of 50 nodules underwent surgery. There were 37 malignancy and 13 were benign. So this was a breakup of TERADS and Bethesda. And so we need a gold standard to assess the diagnostic accuracy of ACR TERADS. Surgery would be the ideal gold standard, but it is unethical to perform surgery on all Bethesda 2 nodules. So Bethesda 2 report was considered as final, and all other nodules, Bethesda 3, 4, 5, and 6, who underwent surgery and have a definitive report of benign or malignant were included as a final outcome. So the final outcome variable was the gold standard against which we assess the diagnostic accuracy of ACR TERATs. And of this 370 nodules, 295 nodules had a final outcome verdict, and 37 nodules were malignant. That's around 12.5%. 33 were papillary carcinoma, 3 follicular carcinoma, and 1 Hurthle cell carcinoma. For the predictive accuracy of ACR TERATs when compared against its final outcome result, it was 100% sensitive. So specificity was 60.5% and negative predictive value was 100%. So it has got high sensitivity and negative predictive value, whereas the specificity is lower. So just like all other studies say, it is a very good test to rule out malignancy, not to rule in. And the comparison of the diagnostic accuracy with previous studies, our study had 100% sensitivity, almost comparable with the previous studies. Why our sensitivity was a bit higher is because we included more smaller nodules for evaluation. That's why. And the specificity is almost similar with the other studies, 60.5%. Now, the predictive accuracy of size cutoff criteria put forward by ACR TERATs. In the study, 173 nodules did not satisfy the size cutoff criteria, and the sensitivity was 78.4% and specificity was 63.95%. It had good negative predictive value, 95.4%. So the negative predictive value is there, but the sensitivity and specificity are okay, average. And the chance of missing malignancy and unindicated biopsy is 8 in 173. That is, if you go on doing 22 more unindicated biopsies, you are likely to pick one more malignancy. The clinical significance or the follow-up significance of finding it early, that is questionable, but that is a statistics. Like the number needed to treat, we say for certain drugs. The performance of individual ultrasound features in predicting malignancy. Solid nature and hypoechoic nature had better sensitivity, but specificity was good for taller than wide nature, lobulated or irregular margins, and extrathecal extension, punctate echogenic foci, and the presence of suspicious lymph nodes. Presence of suspicious lymph nodes with loss of fatty hilum had good specificity. But what we observed is that this taller than wide nature, that is a less frequently reported thing in the reports, ultrasound reports. Indeterminate nodule, that is 3, 4, and 5 nodules. We had 41 of indeterminate nodules, 19 of them underwent surgery, 14 were malignant, and 22 indeterminate nodules were on follow-up. Now, with this final outcome variable, like benign or malignant, we compared the baseline characteristics which are predictive of a malignancy. And on comparing this, a lower age and a higher TSH, even within the normal range of TSH, were associated with increased risk of malignancy. Anti-TPO antibody status was not significantly different between benign and malignancy. On reviewing the literature, the influence of age of the patient on thyroid malignancy, it is well known that lower the age, the chances of finding a malignancy in a thyroid nodule is higher. This study shows that between the ages of 20 and 60 years, each advancing year in age was associated with a 2.2% reduction in the relative risk of malignancy, and that gets stabilized at around 60 years. And the TSH level, there are numerous studies showing that a higher TSH was more associated with malignancy, even within the normal range. And this paper by Moon et al., they have taken all Bethesda 1 nodules, and they have assessed the ultrasound risk stratification system, each ultrasound characteristics of those nodules, and assess the risk of malignancy, whether any ultrasound character is predictive of malignancy. And they also found that lower age was predictive of malignancy, and echogenicity, margin, calcification, vascularity, all those ultrasound features, when they are combined, that is, if the presence of 2 or more suspicious features on ultrasound, that is more predictive of malignancy. It has good sensitivity for predicting malignancy when they are combined. And so with this data, we formulated a prediction score for thyroid malignancy, clinical prediction score, and it's called as Trivandrum prediction score with age, TSH, ACR TERAT score, and the Bethesda category. Age less than, if your age is less than 40 years, you give 1 point. TSH more than 2 or history of hypothyroidism on treatment, you give 1 point. ACR TERAT score -1 is given a score, and Bethesda category -2 into 2. Each of these variables, the correlation curves were drawn on logistic regression, and the slope R-square value was used for giving weightage points to formulate such a formula. And we wanted to give a 0 score for Bethesda 2. That is why Bethesda 2 -2 into 2 was given. to adjust that weightage point. So this was the formula for calculating TIP score. And an ROC curve for finding out the cutoff of TIP score was formulated, and a total score of 6 or more had a sensitivity of 96.2% and a specificity of 97.5% in predicting malignancy. So you can see that the specificity has increased when you're using ASA pteroids alone. Many of the times you are left with ASA pteroids alone to predict the malignancy, when in case of Bethesda 1, Bethesda 3 or Bethesda 4, what we have is only the ultrasound characteristics to predict the malignancy. And in those situations, ASA pteroids, the specificity is only 60%, whereas the score has a specificity of 97.5% with a similar sensitivity of 96.2% in predicting malignancy. On review of literature, earlier Mehta et al. Has already published a cumulative score using adding the Tirads and Bethesda, just like that. And they have found that a score of more than 7, you add Tirads and Bethesda score, gave a sensitivity of 92% and specificity of 74%. Now the subcentimetric nodules, which we are talking about. In the study, there were 31 subcentimetric nodules belonging to Tirads 4 or 5 category. There was 6 of them were malignant papillary carcinoma, 2 had pretracheal lymph node involvement in ultrasound, and 1 patient had pelvic bone mets. That patient had multifocal papillary microcarcinoma. So all these patients, FNAC were not indicated. And so what is the clinical significance of finding these nodules? Let us do a review of the literature. And because all microcarcinomas don't behave the same, they within itself they are a heterogeneous group actually. This Ito et al. There's a long 10-year-long follow-up study of papillary microcarcinoma. If you don't treat papillary microcarcinoma, what is the outcome? 90% remain unchanged, 7% had increased in size, and 9% had decreased during their active surveillance. And in Ito et al. Have found certain risk factors which can be attributed to within quotes aggressive nature within this subcentimetric, that's microcarcinoma. They found that younger the age, or if there is a pregnancy, history of pregnancy with this nodule, or if the size is enlarged by more than 3 millimeter, all these were associated with increased chance of being aggressive among those indolent group. And the tracheal cartilage invasion, if the angle between the tracheal cartilage and the nodule is obtuse, it is a high chance that it may progress for lymph node mets or others, or increase in size. And there are molecular markers like high K67 labeling index, BRAF mutation or TERT mutation, TERT promoter mutation, that were associated with increased chance for aggressiveness. And another study by Kalzewski, which has shown that multifocal and bilateral papillary thyroid microcarcinoma with a diameter more than 0.5 centimeter should be treated aggressively as true cancer and might benefit from lymph node dissection. So this is not a recommendation, but this is a study. This is what they have observed from the study. Now about the follow-up. In our study, 22 indeterminate nodules who did not undergo surgery at the initiation of study, they completed 1-year follow-up. And we did a repeat ultrasound to look for an increase in size. And 4 of them showed a significant increase in size at 1-year ultrasound. And they underwent a repeat FNAC. And 2 of them turned out to be malignant on surgery. And 19 Bethesda 5, Tirads 5, Bethesda 2 nodules. That is Tirads 4 and 5, Bethesda 2 nodules. They are also on follow-up, and they are on. The follow-up is ongoing, not complete now to say a conclusion. But so far, 1 nodule has developed an increase in size, significant increase in size, and it has underwent ultrasound guided repeat FNAC, and it was Bethesda 6, and it underwent surgery. So what are the follow-up recommendations put forward by ATA? ATA says that those nodules who had an indication for surgery and who had an indication for FNAC, after benign FNAC, if the ultrasound is highly suspicious, you do a repeat ultrasound and ultrasound FNAC at 12 months. If it is low to intermediate, repeat ultrasound at 12 to 24 months, and very low suspicion, repeat at more than 24 months. You're more relaxed. And if any nodule has 2 benign FNAC reports, then you can leave that alone, that it is benign. And follow-up recommendations for nodules that do not meet the FNAC criteria initially, it is almost similar. High suspicion, you repeat at 6 to 12 months, low to intermediate at 12 to 24 months, and very low suspicion at more than 24 months. But the ASA pteroids, the follow-up recommendations of ASA pteroids are more liberal. they says that scanning intervals of less than 1 year are not warranted. And for a TIRADS 5 lesion, you can repeat ultrasound every year for 5 years. TIRADS 4 lesion, ultrasound should be done at 1, 2, 3, and 5 years. TIRADS 3, you do it at 1, 3, and 5 years. And imaging can stop at 5 years if there is no change in size, as stability of the time span reliably indicates that a nodule has a benign behavior. So you have been following up the nodule for 5 years and you know that it is benign, you can now leave it alone. So now to address the challenges in evaluation of thyroid nodule, summarizing our observations and suggestions, there's nothing new. We all know this actually. We should look into the patient characteristics, individual patient characteristics, the age, the TSH, family history, exposure to radiation, everything we need to probe into before taking a decision. Then ultrasound characteristics, each of those ultrasound characteristics we have to intersect and assess how it is, how the chance of malignancy, understanding that this ultrasound risk stratification is mainly for papillary carcinoma, follicular carcinoma. It might be different. Only 30% of 20 to 30% of them is hypoechoic or may show a microcalcification. 25% show a microcalcification. And on Bethesda also, follicular carcinoma usually is reported as Bethesda 3 plus or Bethesda 4. So keeping all this in mind, we need to dissect out each of the ultrasound characteristics and get an idea of the risk. Then you can use cumulative risk stratification systems, prediction scores like the one tips to assess the risk before taking a decision for surgery. And cytology review, that is very important. From our experience, we came to know that many of the Bethesda 3 reports are mainly due to a drying artifact. If you keep the slide out for some time and allow it to dry, there are nuclear changes which can mimic papillary carcinoma Bethesda 3. So you have to immediately put in the isopropyl alcohol. So when you are assessing or analyzing the report of an FNAC done by some other person, we are not sure whether it is actually from the candidate nodule, whether any of such technical errors are there, like we say the lab assay interferences. We need to do that. We can go for a repeat FNAC and inform patient preference. We rather than giving a binary opinion to the patient that it is benign or malignant, you can discuss with the patient regarding the risk. What are the chances of you being a benign or being a malignant, and what are their preferences? Are you willing to take this risk, or are you willing to come for a regular follow-up and take a combined decision based on the patient as well as the doctor preference? And optimal follow-up. You need not go for an aggressive, very aggressive follow-up and burden the patient, or you don't relax too much. Should be an optimal follow-up. And there's a saying, an unpopular saying, that around 10 to 15% of patients visiting an endocrinologist OP does not have a thyroid of their own. So we need not go very aggressive, nor we need not relax too much. That's the crux of my study. Thank you so much.
That was an excellent presentation and excellent work done from the medical college team. Well, you forgot to highlight 3 important challenges that consultants or people who work outside institutions face. The radiologist who does the thyroids. There is most of the time, it has become fancy to put the thyroid score. When we go through the report, there is absolutely no correlation between the thyroid score. They will write taller than wide microcalcification, everything in the report, and at the end the score is thyroids 3. So we thought thyroids will help us to guide, but ultimately again we have to read the ATA, maybe the type of things that go into the thyroid. So when we incorporate a scoring system, we have to remember who is doing that. Every person, it may not be possible to have the same guy doing the ultrasound. So we have to find out in each hospital. People like me who run from one hospital to another hospital have to find out radiologists specifically that to get, but still the patient comes with a thyroid score not at all matching the features. Then again, now I have an endocrine surgeon doing most of my FNACs and ultrasound also. So a lot of reports previously FNAC that had come as blood only, cell seen, have miraculously now, as you said, have undergone surgery now, because once a specialist or a person who has experience in doing these things, the Bethesda comes back as FNAC, PAPCA, we do a surgery now, everything. So Actually, my this one goes up with the patients. So this patients think that over a period of 2 years, I have exactly picked up the cancer as soon as I've heard them bringing another. This is a doctor who picked up at that moment. Ultrasound became, or the time MNG became a PTC, and I picked up. I don't know what was the report 2 years back. It was so. These are the two challenges that we face, and that is why maybe prediction score like this do not help us, because the Thyroids as well as the Bethesda many a times is not reliable. But it's a really commendable work, and I hope, I'll utilize the tips is I can tell the patients it's a T2 score also. Tips works anyway, so I can modify to my liking also. So any questions, please?
I think so. We are running late now, so we can entertain on 2 questions, max 2 questions.
Excellent talk. I have just one query regarding one low risk PTC you mentioned with pelvic mets. Did you review the slides of that patient? Can it be a diffuse sclerosing variant?
So actually, it was
one patient with multifocal PTC.
Multifocal. Like the HPR was reviewed by a senior pathologist also. It was a papillary carcinoma classical variant only, sir.
Okay, classical variant.
Classical variant, sir.
Rarely, I had one case. Patient initial imaging that told it's probably thyroiditis, but it was something abnormal. Patient has a very bad course, and FNAC turned out to be a diffuse sclerosing variant. So it can be something like that.
Okay.
Thank you. Thank you, sir. Next patient will implore that, sir.
Any comments from anyone? I think because T is waiting outside, and people are reluctant to ask questions because of that. Anyways, it was an excellent talk. Okay.
Dr. Soumya, I must confess that I missed part of it. This, what was your malignancy rate? I must have missed it. You must have talked about
it. 12.5%.
No, in 3 and 4 specifically. Categories.
Categories, sir. All the 3 nodules did not undergo surgery, sir. Among the 31 Bethesda 3 nodules, only 9 underwent surgery. Others are on follow-up. And among the 9, 6 were malignant. That 9 was selected because of a high-risk ultrasound picture. There was a bias there. So out of that 9, 6 were malignant, sir. And Bethesda 4, 3 out of 5, Bethesda 4 was malignant, 66%, sir.
No, sir, that's small numbers, but still, sir, I think that is one of the things. Our Bethesda malignancy rates are much higher. Velour data, our data, I think all of the things point in the same direction, meaning the malignancy, risk is not what is mentioned in the ATA guidelines. 20%, 30% is not that much higher than that.
Okay. Thank you, Dr. Praveen. I think it's because of the time factor. And I said, let me close the session, and it was an excellent presentation. Thank you very much. Okay, declare session is closed.
Thank you, sir.
Thank you, chairpersons and speakers, for the wonderful discussion. So we have come to the end of the first session. As we are running short of time, we'll break for tea just for 10 minutes, and we'll gather back here in the hall by around 11:55. Thank you.
Before you disperse for the coffee break, okay, Trivandrum Medical College and Travancore Endocrine Associates, we are conducting a CME, the 2-day CME for practicing physicians and endocrinologists. The first session on 18th June, that's mainly postgraduate program, followed by whole day, 1-day program of CME for practitioners. Okay. If you want to register your names, you can contact Dr. Abhilash Nair, and please to attend the meeting and make it a grand success. Thank you very much.
Welcome back to the second session. So the next talk will be on thyroid dysfunction with newer anti-cancer therapy. For this, I invite Professor M.V. Muralidharan sir. Sir is a senior most endocrinologist from Kerala, and also Dr. Vimal M.V. Dr. Vimal is a consultant endocrinologist at Aster MIMS, Calicut.
Friends, first of all, I thank Professor Harish Kumar and my friends in Amrita who have invited me to take part in this session on my behalf and also on behalf of my co-chair, Dr. Vimal. The topic today that is thyroid dysfunction with a newer anti-cancer therapy. If you take this field, cancer chemotherapy has been changing regularly from what we were students with anti-metabolites and similar thing. It has gone to things like better differentiation of tissue, which was discovered in promyelocytic leukemia long ago by using all trans-retinoic acid. Then we came the kinase inhibitors, which is used in thyroid malignancy. And finally, we have got immune checkpoint inhibitors, which are important in producing a number of endocrine problems, not only in thyroid, but many other, like pituitary, pancreas, adrenal, all of them are affected by immune checkpoint inhibitors. And I hope the speaker would cover this area of thyroid dysfunction and the treatment of malignancy. I invite Dr. Vivek Matthew to give his talk.
Dr. Vivek Matthew doesn't need any introduction to our audience. He has done his MBBS and MD from St. John's National Academy of Health Science at Bengaluru, as well as DM from the same in APGMR Kolkata. He is a prolific speaker. And over to Dr. Vivek Matthew to tell us regarding the thyroid dysfunction in the newer anti-cancer drugs.
Thank you, Murli sir and Praveen, for those kind words of introduction. And I would like to thank Amrita team, Dr. Harish, Dr. Praveen, and Vasanta madam for giving me this opportunity. So this is my topic, thyroid dysfunction with newer oncological drugs. If you look into the newer oncological drugs, I think Dr. Melissa has already given you an introduction. So these are some of these drugs that do cause thyroid dysfunction that is associated with oncology. So interferons and interleukins now they have given way to better drugs in oncology. You see alemtuzumab that has been existing previously as a treatment for CLL. It was withdrawn. Now it is mostly used for relapsing remitting MS. And so that does produce Graves' disease. I will not discuss that today. Thalidomide analogs, we have bexarotene, which has been classically described in the textbooks as causing central hypothyroidism, but I'm yet to see that being used. For the purpose of today's discussion, I will focus on tyrosine kinase inhibitors and also the immune checkpoint inhibitors. We do use tyrosine kinase inhibitors for thyroid cancers, but probably it is increasingly being more used in other cancers. Now, some of these tyrosine kinase inhibitors, sunitinib, sorafenib, pazopanib, vandatinib, has been associated with hypothyroidism, right? And even in those patients in whom there's a thyroidectomy that has been done, some drugs like imatinib can actually increase the requirement for the thyroid hormone. So that is also there. And then we have the immune checkpoint inhibitors. I will speak in a little bit detail about the immune checkpoint inhibitors. So first we will discuss the tyrosine kinase inhibitors and thyroid dysfunction. Then we'll go to the immune checkpoint inhibitors, and then I will summarize. So I'll start with one of the case I have seen. This is a gentleman, I think 70-year-old gentleman with hepatocellular carcinoma. He has had a transarterial embolization and a right hepatectomy. Now he has got mets in the lungs, intestine, and ribs. He is a type 2 diabetic, and I have been basically seeing him for type 2 diabetes. So because the disease has progressed, the oncologist have started him on lenvatinib. That is basically one of those newer TKI multikinase inhibitors. It was started at 4 milligram and then subsequently increased to 8 milligram. So in Jan 2021, we have a TSH that's around 2.0 and with a normal free T4. So he was basically referred to us because this TSH subsequently elevated and there was some amount of dyslipidemia. So in August 21, he has an elevated TSH of 12.33. So nothing was done at that point of time. And in October, we have a TSH of 17.42 and a free T4 that was normal. His antibodies were estimated and that was negative. Ultrasound was fairly normal, nothing significant. At that point, he was initiated on a levothyroxine 50 micrograms, following which the thyroid TSH became normal. This is second case. This is again another diabetic with subnephrotic proteinuria. He has a history of CAD, post-CABG. He's got a renal cell carcinoma with multiple mets, liver, lungs, and bone. He was initiated on pazopanib, again one of those newer TKAs. So this is what happened. Just before the initiation of pazopanib, as you can see, the TSH is around 1.28. It rose up to 12.4, subsequently increased to 18.2. His antibodies are negative at this particular point of time. Ultrasound is unremarkable. Now he initiated around 50 micrograms of L-troxin in him, slightly improved, but the pazopanib was continued. And then the TSH increased to 9.01. And then at the end of February 22, that's just last month, he is fairly stable. So with this introductory two cases, I'll just discuss quickly on some of this major TKIs that we actually see. Most of the TKIs that is being used are multi-kinase inhibitors. So we see this tyrosine kinase that is present in the cell surface, okay? And the tyrosine kinase inhibitors will prevent the phosphorylation of this tyrosine kinase, and then subsequently it will prevent the second messenger growth system. So it may actually prevent the MAP kinase ERK pathway or a PI3 kinase mTOR pathway, and thereby the tumor cells may be destroyed. The sorafenib, as you know, it has activities against the VEGFR and PDGFR. This is one of those earliest TKIs being used. Now the newer TKI is the one that I mentioned, pazopanib and lenvatinib. That is being used in many of the patients and the oncology setups. They have a predominant action on the vascular endothelial growth factor receptors mainly, so they can cause a devascularization and tumor apoptosis. Now, what do these tyrosine kinase inhibitors do? They can induce hypothyroidism in around 20 to 40% of the patients. The highest incidence is generally with sorafenib, sunitinib, and imatinib. If thyroid kinase inhibitors can also increase the thyroid hormone requirement. The mechanisms of this, I will just come in the next few slides. This thyroid dysfunction is dose and cycle dependent. You increase the dose and you go into multiple cycles, the thyroid dysfunction may progress. This thyroid dysfunction could develop as early as around 6 weeks, but mostly we see it around 3 to 5 months. And generally it tends to be very mild. So these are the mechanisms. Now in a patient with an intact thyroid, what generally happens is that I told you there is a destructive thyroiditis that occurs because of the devascularization. This is what happens. For example, if you use imatinib in patients who have had a thyroidectomy, what you will see is that there is a slightly increased dose requirement. And why does this occur? This occurs because the tyrosine kinase inhibitors can bind to D3 and promote the deiodinase 3 activity. So there is a consumption of this thyroid, that hormone that is there. So that is one way of doing. And then the other way is we have the MCT8 transporter, which is present in the brain and the heart. So this tyrosine kinase inhibitor could bind to this MCT8 transporter, and they can, I'm so sorry, and the transport of T3 into the cells can be inhibited. Again, the T3 acts by the binding of RXR with the T3 receptor, the heterodimerization. this heterodimerization can also be inhibited by the TKS. So there is a problem with an impaired T3 transport into the cell and also T3 signalings. So these are the multiple ways, major ways in which the TKIs would provide or to produce a thyroid dysfunction, and it can also increase the thyroid hormone requirement. There are some other less important ways like the TSH bioactivity because of increased stylization, decreased TRH action, increased DIO2, etc. But these are probably not too important, but this also there. So what about the diagnosis? The diagnosis is mostly based on TSH. The patient may not be really symptomatic because the clinical signs of specificity is poor because it is a mild hypothyroidism. But this could actually affect the patient's quality of life, and many times the patients may attribute these symptoms to the chemotherapy, and this may actually lead to the dose reduction of various chemotherapeutic drugs. But patients are being increasingly aware. The other day, I had a patient who came to me and said that I've been started on lenvatinib. I read up about it, and that does cause thyroid dysfunction. So I've stopped the drug. So I told them, ma'am, the thyroid dysfunction can be easily be treated, but your hepatocellular cancer may not be easily be treated. So please do take it. So that the positive takeaway would be that patients are increasingly being aware. The thyroid antibodies, that may not be really helpful. It may be there or it may not be there, especially in the early phases, you may not find it at all. But as the time progresses, you may actually find these antibodies being present. That is probably because the autoimmunity may be worsened by the TKS. If you do an ultrasound, you could see the classical thyroiditis picture, or you may actually see a hypervascularity or decreased vascularity in the ultrasound. Most common presentation is hypothyroidism, but these patients could go through an initial transient thyrotoxic phase, which is very mild, and most of the time that is missed. Like I told you, this hypothyroidism is generally tends to be very mild, and it is easily treated. And once the TKS are stopped, in many patients, especially in the early years, the hypothyroidism could be reversed too. The problem is that once the TKS are stopped for one particular reason, in many patients, because of the adverse events, we do find the TKS being stopped. So even the thyroid function normalizes, what we do find is that the primary disease progresses. The TKS are invariably continued. So how do we monitor when the patients are on this TKS? So in those patients who are euthyroid, if you notice how the TKS are being given, medicines like sunitinib could be given in cycles, or they can be given continuously. So if you are giving it in cycles, you could monitor at the beginning of each cycle. If you are giving it continuously, you could monitor it once every month for the initial 2 to 3 months, and once to 6 months. And after that, you could do it once in every 3 months. In those patients who are already on thyroid supplements, here, remember, what can happen is that your dose requirement could be increased. So you need to monitor these patients monthly for around the first 3 months. And after that, once in every 3 months would be sufficient. So with that, I will go into my second part of the talk. Now we are going to deal with immune checkpoint inhibitors here. So again, I will start with a case. This is an Arab gentleman. He had malignant melanoma, again, quite advanced. So he was started on pembrolizumab. Pembrolizumab is a PD-1 inhibitor. I'll come to this in these details in a little bit. So after 2 doses of pembrolizumab, which is basically given 1 in every 3 weeks, he came to us with breathlessness and tachycardia. So you could see a thyrotoxic picture with low TSH and elevated free T4 and free T3. And the technetium uptake, you have a classic picture of thyroiditis. So he was conservatively managed. The disease was not very severe, so we decided to continue the pembrolizumab. 4 months back later, he developed hypothyroidism. At that point, levothyroxine was initiated. He's still on follow-up from his country, and his TSH is normal, and he's still on pembrolizumab. This is a young lady who was diagnosed with Hodgkin's lymphoma in 2017. She had undergone multiple chemotherapeutic cycles. Then I think she lost faith in modern medicine, and she went to Ayurvedic treatment. So 1 year later, she returned again. She was frankly Cushingoid. So she was initiated on nivolumab, again, another PD-1 inhibitor. So after a single dose, she came to us with breathlessness and weight gain. The endocrinology consultation was basically for obesity, but on examination, she was Cushingoid. she was anxious, there were severe tremors, and she couldn't even stand because of the tremors that she was facing. So what did we find? There was a cortisol that was very low, and probably suggestive of an HP axis suppression. The ACTH and stimulation test was also inadequate. The TSH was low, and there was severe thyrotoxicosis, as you can see from the free T4 and free T3. The antibodies were negative, and the rest of the pituitary function was fairly normal. So we have the ultrasound that was done. The ultrasound was fairly normal, nothing major to be detected. The technetium uptake, as you can see, there is a decreased uptake in the thyroid, suggestive of thyroiditis. An MRI brain was done, which showed a minimal thickening. I think it was 3 mm, if I'm not sure, of the pituitary stalk. And there was a 1 millimeter pituitary adenoma. So our diagnosis at this point was nivolumab-induced thyroiditis. HP axis suppression was suspected, and possibility of a hypophysitis was also considered in view of the minimal thickening of the pituitary stalk. So she was treated with beta blockers and hydrocortisone. In view of her severe symptoms, the decision was taken to stop nivolumab. We followed her up, and her thyrotoxicosis evolved into hypothyroidism, and she was initiated on thyroxine replacement. We continued the hydrocortisone, and subsequently we took a decision to restart the nivolumab. 1 year later, her HP axis suppression has recovered, and thyroxine replacement is still ongoing. So these immune checkpoint inhibitors actually have they're present with a double-edged sword. They can give you the desired effects. At the same time, they can harm the binders and bystanders. Okay, so I will just come to the checkpoint inhibitors. The checkpoint inhibitors, we have basically two classical different types. We have PD and PD1, that is programmed cell death protein 1 and programmed cell death protein ligand antagonist. So what it does is that if you look into the picture, you have your natural killer cells that is there. I don't know whether you can see it. I'll use this, yeah. You have your natural killer cells that is there. So normally the killer cells has this T cell, normally the T cells have this T cell receptor that will bind to the antigen from the tumor cell, right? So at this particular point of time, the tumor cells could also produce a ligand known as the PD-L1 ligand. Now, if this PD-L1 ligand binds to this programmed cell death 1 protein that is there, so what will happen is that it sends some suppressive signals into the T cells. Now, because of the suppressive signals, the T cells fail to become activated, and the tumor cells will be recognized as a body protein, and the tumor cells will escape the cytotoxic effects of the T cell. But if by some way this interaction can be blocked, as you can see here, by using a PD-L1 or an anti-PD-1, then the T cells will be activated, and that will lead to destruction of the tumor cell. Now, cytotoxic T lymphocyte 4 inhibitors, that was a slightly complex mechanism. Again, this is not working. I'll try to, yeah, maybe. So if you look there, you have your T regulatory cell or an inactive T cell. Now, this inactive T cell will bind to the MHC complex from the antigen presenting cell by the T cell receptor. At the same point of time, you could also see on the right side, the CTLA4 and CD20 will bind to B1 and B7-2. But if this binding occurs, what will happen is the inactive T cells will not be activated, and further recruitment of the T regulatory cells and further cytotoxic activation does not occur. But if you have, let's say, a CTLA4 inhibitor, which would prevent this binding, again, that the regulatory T cells will become activated, and second messengers could be sent to activate the immunotherapy, the cytotoxic T cell action. So this is the basic mechanism. So the PD-1 inhibitors or the programmed cell death inhibitors are nivolumab and pembrolizumab. I have seen only these two being used. I have not seen any other being used. The PD-L1 inhibitors generally I have not seen being used. The CTLA inhibitors are ipilimumab and tremelimumab. As Dr. Melissa was explaining, it has a wide effects on the endocrine system, not only the endocrine system, all over the body. So with the endocrine system itself, we are looking at hypothyroidism, hyperthyroidism, hypophysitis, hyperpituitarism, adrenal insufficiency, and type 1 diabetes. But one of our patients presented with the lady with Hodgkin's lymphoma. She presented with severe gastroenteritis, which went on for around 3 to 4 months, very difficult to manage. And the second chap, the one on pembrolizumab, actually presented with pneumonitis, which is also slightly severe, but it will be easily be managed. The important aspect of these endocrine effects are most of these endocrine effects have a distinct time to emerge, and most of them will emerge at the end of 5 to 6 weeks. So that is the time you have to watch for any emergence of thyroid dysfunction or other endocrine effects. This is just an explanation of what is going on here. So what they have seen in the thyrocyte is, please see the right side. You can actually see that they have found that with the use of PD-1 immune checkpoint inhibitors, there is an initial infiltration of the thyroid cell by monocytes. These are the monocytes which express the CD14 and CD18, and there has a binding with the HLA-DR3 complex, and there is an increased expression of PD-L1 and PD-L1 ligands in the thyrocytes. Now, with this interaction, you can actually see the thyrotoxic, the thyroid, you can actually see that the cytotoxic T cell immunity is being activated, and there is a cell-mediated cytolytic reaction that occurs. So with the immune checkpoint inhibitors, what you find most commonly is that subclinical thyrotoxicosis is what you mostly find. And overt thyrotoxicosis is also there. And finally, overt hypothyroidism. What are the predictors? The predictors are generally females and younger age group, but there are some reports that say that older age group are also involved, and in them hypothyroidism could be more common. So the overall incidence of thyroid dysfunction could be as high as 40 to 45%. But if you combine, sometimes oncologists do combine both together to get a better response, PD-L1 and the CTLA inhibitors, and then the thyroid dysfunction could be as high as 60%. The other important finding was the BMI. And what they did find is, interestingly, is that those people who had a higher BMI, they had a higher incidence of thyroid dysfunction, and they had a higher incidence of thyrotoxicosis. But this BMI did not have any relationship with hypothyroidism. Somehow they had a very high immune reaction in their body. So when you look into the clinical features of immune checkpoint inhibitors induce adverse effects, you have an initial thyrotoxicosis followed by hypothyroidism. But contrary to the tyrosine kinase inhibitor, you will not miss this thyrotoxicosis because these tend to be severe, and the patients will report to you. And even the thyroid storm has also been reported. Autoantibodies may be there or not. So, but the patients who have autoimmunity, they have a higher chance of developing these symptoms. When you look into ultrasound, you can actually see a transient hypervascular hypertrophy if you manage to do an ultrasound at that time, and subsequently a classical hypoechogenic appearance. So for monitoring, before beginning of each cycle, a thyroid function has to be done. After that, once in every 6 weeks, you could monitor the thyroid function. Even after stopping the therapy, the recommendation is to do the TSH annually. For hypothyroid patients, do a TSH once in every 4 to 6 weeks. Now, is it really bad, or are we crying wolf every time the patients develop a thyroid dysfunction? So what is actually been seen that in those patients who developed a thyroid dysfunction or a thyrotoxicosis, they had a better overall survival and a progression-free survival, telling that the immune response in them was quite good, or so this thyrotoxicosis development may not be actually a bad sign. This audience will not need this management slide, so I'll skip that. So the first time I faced with problem, I was asked this question: should we continue this or should we stop this therapy? So I didn't have any answers at that time. So I looked at the patient, and the patient, she was quite bad. I said, okay, fine, let us stop this. And subsequently, when she's improved, and when I was posed this question again, I said, let us restart again. But then most of the expert opinions actually has come up with this. This is basically CTCA. This is a common terminology criteria for adverse events. So what they say is that they divide the patients into 5. Grade 1 is asymptomatic. Grade 2 is those who are symptomatic with a minimal effect on the activities of daily living, like driving, cooking, etc. Grade 3 are those patients in whom hospitalization is required. Even self-care activities are affected. Grade 4 is life-threatening consequences, and grade 5 is death. So one fancy way of describing this is that you can hold the immune checkpoint inhibitors if thyroid or any other organs are affected, if they have a grade 3 or 4. And if it is grade 1 or 2, you could actually continue this treatment. And if you could manage the symptoms by supporting therapy, again, ICS can be continued or restarted. So I would summarize this. Thyroid-related adverse events are common with immune checkpoint inhibitors and TKIs. They would need monitoring and management according to severity. And most importantly, it may not be really bad, but thyroid-related adverse events may predict treatment response with immune checkpoint inhibitors. Thank you so much.
Thank you very much for the excellent talk. Any comments or questions from the audience on this area? Because we are going to see, even though we may not be giving these drugs for them to develop a thyroid problem, we are asked to control or treat some of these issues which are produced by the oncologist or many other people who are using either ICPI or a kinase inhibitors. That is why you come to get sometimes the oncologist saying, I'm treating this patient for renal cell carcinoma and he has developed thyroid dysfunction. What to do? What medication should I give and what should be the plan of action? So that it will come. And this is going to be increasing because these are considered to be less toxic in the treatment of malignancy, even though costlier at present. But they are going to be used more and more, and you will get this endocrine problem, especially that of the thyroid. So, any comments on the house?
Yeah. Sir, I have a comment actually. Dr. Vivek, congratulations on an excellent presentation. Actually, I will just share my one experience. Actually, nivolumab. One patient was on nivolumab, and the patient was had some severe tiredness. They did TFT, and it was found to be severe hypothyroidism. TSH was around 40-45. So what I did is I also did a cortisol. It was less than 1. So the patient was not on steroids. So probably it's a combination of hypophysaris plus primary hypothyroidism, and I think it will be worthwhile to screen for cortisol for every patient before initiating on thyroxine therapy. Even if that is 50 or 100, probably I think it can even affect the corticotropes selectively. Some of the, even nivolumab. So that's my. So what I
So
think
that we suspected that here also. But she was frankly Cushinged because of the large amount of steroids that is being given for her, and some of them actually described that if there is a hypophysitis. I don't know what you did. A patient recover from that? This hypophysitis?
No, that actually we have done cyanactin test recently also, but he's still having hypo. He's continued on nivolumab. I have follow up of 6 months to 1 year.
So the thing is, they say that if they develop hypophysitis, the chances of recovery from the recovery of the adrenal function is quite less.
Yeah,
So it could be
he's
actually be
still, yeah.
permanent. So in our patient actually recovered. So that is why I thought probably it is more of HP axis
Yeah,
suppression.
I
rather
actually
than-
discussed this patient with the oncologist. They said that it was very minimal dose of steroid which she received around 1 year back, and unlike it to be an exogenous suppression or something, she had no clinical pictures of exogenous Cushing's also. Probably it's isolated ACTH axis involvement or something.
Yes.
Yeah.
There are, yes, Praveen, you want to ask something?
No, sir. Vivek, excellent presentation, as you should. So this, when you restart the medication, is there some sort of pattern, meaning you had some severe disease, so it gets better as time progresses, something like that? For example, you had a severe thing, you stop it, and after some time you are going to restart. So some sort of pattern is there, or it gets lesser with prolonged?
You mean the endocrine side effects?
Everything in general.
Oh, okay. See, what generally what we see is all those patients who developed, I mean, at least from the minimal experience that we have, all those patients who developed this kind of side effects, they did in the initial period, right? And most of these effects, like most of the endocrine side effects, will develop in the first 6 to 8 weeks. Similarly, there is a cutoff for most of the other diseases also. I think I forgot that I would have shown that graph. And once it develops and once improves, the patient improves from that, then you do not find much of these things being repeated over a period of time. But sometimes this could be so severe for that girl that, I mean, we had to admit her, and she was on a peg was inserted, and she was on this kind of therapy for maybe 4 or 5 months. And they even suspected some sort of fungal gastroenteritis and everything, but it didn't improve. So this thing, whatever that happens, that may take a long time for improve. But then if they come out from that, they generally have a better prognosis. And none of these patients from maybe around there, I would have seen around 8 or 10, and none of them actually had a recurrent disease that's happening. So they did really well with this. And even though the initial, the phase, that initial worsening of this immune reconstitution that occurred, if you give enough supportive therapy and you bring these people out of that, they may actually give a better response. And then they have also seen that even those patients who are frankly hypothyroid, even in them, this could produce a severe thyrotoxicosis at a later picture. But I would say that most of them would occur during the first time, and the recurrent challenges did not produce much problem for many of these patients. Thank you.
Before I wind up, I would like to add one thing, because the thyroid dysfunction is not exclusively because of a direct effect of the treatment on the thyroid. To an extent, it can also be the fallout of a pituitary dysfunction. You know, hypophysitis and pituitary damage has been described in many of the immune checkpoint as well as inhibitors, and to some extent with the kinase inhibitors. And it is important from the clinical point of view, from the practicing physician, are you dealing with a pituitary mediated thyroid dysfunction? Because if it is pituitary mediated, you may have to also evaluate simultaneously for cortisol, gonadotropins, and growth hormone, according to the relevance. And you have to plan treatment on those planes also when you are managing. That is something from the practice point of view when you are seeing a patient with a immune checkpoint inhibitor therapy and its dysfunction. So I thank you. A good talk by the speaker, so to my co-chairman, and Amrita for bringing an excellent topic. Thank you, sir.
Thank you, Dr. Vivek, and thanks for that team for giving me an opportunity to chair this session. Thank you.
Once again, thank you, chairpersons and the speaker, for the wonderful talk and the interactive discussion. Now, the next talk will be on thyroidology in the pandemic years. For this, I invite Dr. Anish Ahmed, who's a consultant senior endocrinologist at Endo-Diab Center, Perithalmanna, and also Dr. Abdul Majid, sir. Sir would be joining online.
Special thanks to Dr. Harish Kumar and Dr. Praveen for inviting us to be a part of the Amrita Thyroid update. Our next topic is on thyroid problems in the COVID pandemic. As in the previous year, again, we are looking for that there is an abnormal thyroid function results for the thyroid problems as a result of the pandemic. This particular products we will see in three contexts. One is the thyroid disease, autoimmune thyroid disease, and the functioning thyroid levels of problem. Second, the altered thyroid function aspects of the non-thyroid illness or the drugs used for the management. And third, the virus infection may act as a trigger to produce changes in the thyroid gland itself. So I request Dr. Anish Ahmed to introduce the speaker and invite him for the talk.
So thank you, sir. First of all, I thank the Amrita team for giving me an opportunity. So Arjun is the young blood now we have. He has just passed out his DM. And he has completed DM from Amrita, and he's currently working as consultant endocrinologist at Aster MIMS Kannur. Over to Arjun.
Thank you, Anish, for those kind words. Good afternoon, everyone. It's an honor and privilege to speak to you all today. So at the outset, I'd like to thank my teachers at Amrita for giving me this opportunity to speak at this platform. So today I've been given a task to speak about thyroidology in the pandemic years. What is new? So there were many outstanding publications in the past 2 years. So I'll be focusing on key clinical research articles published since 2019 in the field of thyroidology. And for ease of discussion, I've categorized them among these 5 categories: thyroid nodules and cancer, thyroid function and thyroid eye disease, pregnancy, pediatrics, and disparities in thyroid. So articles selected are those that can be perceived as groundbreaking, practice changing, or highly innovative and has the potential to change clinical practice. So I'll be discussing in detail about one featured article and browse through a couple of other nominees. So the featured article selected for thyroid nodules and cancer was a pivotal study by Wirth et al. So as we all know, it is important to identify treatment options for advanced thyroid cancers that can improve patient outcomes yet minimize harm. Targeted therapy is something that offers its promise. So the featured study is efficacy of selpercatinib in RET-altered thyroid cancers. Selpercatinib is a novel, highly selective RET kinase inhibitor. So for inclusion in the present study, patients had to have RET mutant medullary thyroid cancer with or without previous vandatinib or cabozantinib treatment, or previously treated RET fusion positive thyroid cancer. So the primary endpoint was complete or partial response, and the secondary endpoints were progression-free survival and safety. So before going into the results, just a quick overview of RET mutations. So collectively, hereditary syndromes account for almost 25% of all diagnosed MTCs. And of the remaining 75% of sporadic cases, 60% of them harbor somatic RET mutations. RET fusions are also found in less than 10% of differentiated thyroid cancers. So this is a RET proto-oncogene. So it is constitutively activated through two distinct mechanisms. One is the mutations involving the cysteine-rich domain, and the other one is the structural rearrangements which lead to fusion of RET to an upstream partner. So collectively, these alterations lead to ligand-independent signaling and oncogenesis. So selpercatinib is a highly selective oral anti-RET tyrosine kinase inhibitor designed to inhibit native RET signaling, and it is indicated in non-small cell lung cancer, RET mutant MTC, and RET fusion positive thyroid cancers, which require systemic therapy. So coming to the results, patients were categorized into 3 groups. So in the 55 patients with RET mutant MTC who were previously treated with cabozantinib or vandatinib, the percentage who had an objective response was 69%, and 1-year progression-free survival was 82%. In the 88 RET mutant MTC who were not previously treated, 73% had an objective response and 92% had progression-free survival. And in the previously treated RET fusion positive thyroid cancer, 79% had objective response and 64% had progression-free survival. The most common adverse events of grade 3 or higher were hypertension, diarrhea, and altered SGOT-SGPT. So both vandatinib and cabozantinib are approved for the treatment of metastatic MTC. But because of the adverse events associated with them, in the cabozantinib trial, dose reduction was occurred in 75% of patients, and it was discontinued in close to 16%. And in the vandatinib trial, 35% underwent dose reduction and 12% had discontinued the drug. Now, because of the selectivity of selpercatinib for RET, dose reductions were relatively uncommon, and less than 2% discontinued the drug. So selpercatinib showed durable efficacy with low-grade toxic effects in patients with medullary thyroid cancer without previous vandatinib or cabozantinib treatment. Major limitation was that radiographic tumor progression was not an explicit inclusion criteria. Moving on to the next study, approximately 20% of thyroid nodules display indeterminate cytology, that is Bethesda 3 or 4. So nodules with an indeterminate cytology have close to 10 to 40% risk of malignancy. So the usual management has now progressed from either a repeat FNAC and surgery to molecular testing. So this is a study which was published in JAMA Oncology, effectiveness of molecular testing techniques for a diagnosis of indeterminate thyroid nodule, a randomized clinical trial. So participants who underwent biopsy between 2017 and 20 underwent either the RNA molecular testing or the DNA RNA molecular testing. And the outcome was the diagnostic performance of both the tests. So the study included 346 patients, 372 nodules who were randomized to either the RNA test or the DNA RNA test. And clinicians subsequently made the recommendations for either continued surveillance, repeat FNAC, or thyroid surgery. So if you see the results, more or less both the tests had the same specificity and positive predictive value. The specificity of the RNA test and DNA test were 80% and 85%, and the positive predictive value of the RNA and DNA tests were 53 and 63%. So the prevalence of malignancy among indeterminate nodules in the study was close to 20%, and the diagnostic thyroidectomy could be avoided in 51% of patients who underwent the RNA test and 49% of patients who underwent the DNA RNA test. So both RNA and DNA RNA tests displayed high specificity and allowed around 49 to 50% of patients with indeterminate nodules to avoid diagnostic surgery. So a limitation is that non-operative management was there for most indeterminate nodules with benign molecular test results. However, in prior validation studies, which included molecular testing followed by thyroid surgery, there was a high sensitivity reported. It was close to 90%, and the low false negativity report that was only close to 2 to 3%. So papillary thyroid carcinoma often co-occurs with Hashimoto's thyroiditis. So it is an association that has long been reported in clinical studies, and yet it remains controversial. So some studies, in fact, have suggested a protective effect of thyroiditis, while others have not. So the authors generated in this particular study, the authors generated a mouse model where PTC and thyroiditis developed in a predictable manner. So that there were 3 groups: mice with pre-existing thyroiditis, mice with concomitant thyroiditis, and mice with no thyroiditis. So the major finding was that mice with pre-existing thyroiditis lived longer than those with concomitant or no thyroiditis, and PTC developed less frequently in those patients with pre-existing thyroiditis. So only 33% of mice with pre-existing thyroiditis develop papillary thyroid carcinoma, whereas with concomitant or no thyroiditis, almost 100% of mice develop papillary thyroid carcinoma. Also, the PTC showed less aggressive histopathological features in those mice with pre-existing thyroiditis. So this study sheds light on the controversial PTC thyroiditis association and shows that thyroiditis could play a protective role in thyroid cancers. So the sodium iodide symporter is required for iodide uptake, and NIS has been exploited for treatment of radioiodine treatment over the past 75 years. However, the exact mechanism of NIS trafficking remains ill-defined. So this is a study from Kettering Cancer Center, New York, which was published in Cancer Research. So the authors used tandem mass spectrometry and identified and validated two key nodes for NIS trafficking. One is the ARF4 and VCP. ARF4 is the ADP ribosylation factor 4, and VCP is valosin containing protein. So in gene expression analysis, VCP expression was associated more with particularly induced in aggressive thyroid cancers, and patients who had VCP expression had poor outcome following radioiodine treatment. So two reputed FDA-approved VCP inhibitors are there, which is currently used for other neurodegenerative diseases. So if you look at the, so if you look at the NIS trafficking, on top you can see the ARF4, which is in purple color, that causes the NIS to be trafficked towards the plasma membrane, thereby increasing the NIS expression and also increasing the radioiodine uptake. Whereas below, if you can see the VCP, that causes the unfolding of the NIS and causes proteasomal degradation. And this is from the same study where they looked at the VCP and NIS, VCP and ARF4 expression in normal thyroid cells as well as cancer cells. So the VCP expression was significantly higher in the cancer cells, and the ARF expression was significantly lower. And also the VCP expression was highest in anaplastic cancers and then in poorly differentiated cancers when compared to normal thyroid tissue. So these findings show that ARF4 and VCP are involved in NIS trafficking to the plasma membrane, and this highlights the possibility of a therapeutic role for VCP inhibitors in enhancing radioiodine effectiveness in radioiodine refractory thyroid cancer. So this was another study published from South Korea. Growth differentiating factor 15 is a cancer cell-induced cytokine that primes thyroid cancer cells for invasiveness. So mitochondrial stress is known to activate mitochondrial unfolded protein response. And this leads to formation of mitochondrial cytokines, also known as mitokines. And these mitokines are reported to be pro-tumorigenic. Growth differentiating factor is a well-characterized cytokine. So the serum levels of GDF15 were compared in healthy subjects and in PTC patients. So with multivariate analysis, it revealed that gross extrathyroidal extension and lymph node metastasis were independent parameters related with GDF15 expression. Also in this study, when they analyzed the mean GDF levels, the mean GDF levels were significantly higher, close to 3-fold higher in the PTC group when compared to controls. And also the GDF expression was significantly higher in tumors less than 2 centimeters, in tumors with lymphovascular invasion, and in patients with recurrent disease when compared to patients who did not have any recurrence. So GDF15 determined tumor progression in cancer, and GDF15 signaling axis may be a potential target for controlling the aggressiveness of thyroid cancer. Now coming to the active thyroid eye disease and thyroid function category. So the selected article in the thyroid eye disease category is a very familiar article. It is the phase 3 study on teprotumumab in patients with active thyroid eye disease. So teprotumumab is a novel IGF-1R inhibitor, and Douglas et al. Performed a randomized double-blind placebo multi-center trial where the patients were either randomized to receive teprotumumab or placebo. And the primary outcome was a proptosis response, and secondary outcomes at week 24 were overall response, clinical activity score of 0 or 1, mean change in proptosis, diplopia score, and also quality of life questionnaire. While the role of TSH receptor in the Graves' orbitopathy has already been established, IGF-1R also plays a key role in the disease. So teprotumumab is a recombinant fully human monoclonal antibody of IgG1 subclass, which binds to IGF-1R with high affinity. And this blocks the activation of IGF-1R by the endogenous ligands. This also causes the internalization of the receptor. So this leads to complete shutdown of IGF-1R signaling. And the main fact is that it does not show any functional agonistic activity. So it is given in 20 mg per kg infusions every 3 weeks for a treatment duration of 24 weeks. So coming to the results of those treated with teprotumab, 83% had overall proptosis response when compared to 10% in the placebo. And also the additional secondary endpoints were also significantly better in the teprotumab group. The clinical activity score was better in the teprotumab group. Diplopia response, overall response, as well as the Graves orbitopathy quality of life questionnaire was significantly better in the teprotumab group. And the side effects were also minimal. Majority were grade 1 or grade 2. Only 2 patients had infusion reaction, of which 1 had to discontinue the drug. Therefore, among patients with active thyroid eye disease, teprotumab resulted in better outcomes than placebo with respect to proptosis, clinical activity score, diplopia, and quality of life questionnaire. And serious adverse events were uncommon with teprotumab. A major limitation was that long-term follow-up was not present for these patients. So generic levothyroxine preparations are less expensive and have been rated as bioequivalent by the FDA. However, they are not widely used. So the objective of this study was to compare the effectiveness of generic and bland levothyroxine in achieving and maintaining normal TSH among new users. So the design was a retrospective study in adults aged more than 18 years who had a high TSH and was initiated on either a generic or brand name levothyroxine. So patients who had received any thyroid preparation in the past 1 year were excluded, or who switched generic and brand levothyroxine, or who are not willing for adherence. So patients had either 2 outcomes. Either the patients had a normal TSH at 3 months or a high or low TSH at 2 months. So coming to the results, the proportion of patients with normal TSH at 3 months of initiating levothyroxine was more or less similar with patients who received the generic version as well as the brand levothyroxine. So initiation of generic versus brand name levothyroxine formulation was associated with similar rates of normal and stable TSH. In the Indian scenario, we cannot be very sure about what the results will be, but we can plan further research into the same. So major limitation was that this was an observational study and there may be a lot of confounding factors. So this Pradosh had already discussed in detail about this article, so I'll just be skipping through. Most guidelines do recommend LT4 as the treatment of choice for hypothyroidism, but there is a lot of uncertainty regarding the long-term efficacy of other preparations. So here the authors investigated these therapies focusing on hypothyroid patients on stable dose of levothyroxine treatment. So this was a prospective study with 75 hypothyroid patients who were on stable doses of levothyroxine, and they were randomized to one of the 3 arms. They either received LT4, with T3 or desiccated thyroid extracts for a period of 22 weeks. And after 22 weeks, they were again randomized to the other 2 groups. So these were the doses selected as Pradosh had already explained. So the results showed that there were no difference in primary outcomes among all the 3 categories. And also the serum TSH remained well within normal range and varied minimally among all the 3 treatment arms. But in subgroup analysis, there was a small segment of patients who were very symptomatic who preferred the desiccated thyroid extract or the T3 treatment over LT4 alone. So outcomes were similar among hypothyroid patients taking desiccated thyroid extract, LT4 with T3 or LT4 alone. Now coming to the thyroid and pregnancy category. So most clinicians are aware of the adverse effects of undertreatment of thyroid hormone during pregnancy. However, few studies have addressed overtreatment, and this featured article was published in Thyroid Journal, Thyroid Lab Testing and Management in Women on Thyroid Replacement Before Pregnancy and Associated Pregnancy Outcomes. So Lemix et al. Evaluated treatment patterns and relationship between overtreatment and undertreatment, and also with adverse pregnancy outcomes in women on thyroid hormone replacement. So women who had on thyroid replacement anytime during the 2 years before pregnancy were included, and outcomes were levothyroxine dosing and pregnancy outcomes. So I don't think this is visible, sorry. So multiple logistic regression was used to determine if undertreatment or overtreatment was associated with adverse outcomes. So it showed that in the overtreatment where TSH was less than 0.1, any women who had at least 1 TSH less than 0.1 during the pregnancy, it increased the odds of preterm delivery when compared to controls. 16.5% of preterm delivery in the overtreated arm, whereas only 8.2% had preterm delivery in the control arm. Whereas TSH more than 10, it was not associated with any adverse pregnancy or neonatal outcome. So levothyroxine overtreatment in pregnancy was associated with preterm delivery, and clinicians should be careful to avoid overtreatment with levothyroxine in pregnancy. It was a large cohort size, but the main thing was that there can be variability in clinical practice and there can be unmeasured confounders. So this study was the prevalence of thyroid dysfunction and autoimmunity in women with history of miscarriage or subfertility. So this was an observational cohort study where women aged 16 to 41 years with a history of miscarriage or subfertility were trying for a pregnancy. And the main outcome was rates of thyroid dysfunction. So the prevalence of abnormal thyroid function was 4.8%, but overt hypothyroidism was only present in 0.2 and overt hyperthyroidism was present in 0.3%. Presence of subclinical hypothyroidism with an upper TSH limit of 4.5 was present in 2.4%, and if the cutoff was lowered to 2.5, close to 19% had evidence of subclinical hypothyroidism. And TPO antibody was found to be positive in 9.5% of women. So in multiple regression analysis, it showed that increased odds of subclinical hypothyroidism with high BMI and also with Asian ethnicity. So prevalence of undiagnosed overt hypothyroidism is low, but subclinical hypothyroidism as well as TPO antibody positivity are common, particularly in women with higher BMI or of Asian ethnicity, in women with a history of miscarriage or subfertility. So coming to the association between maternal thyroid function in pregnancy and obstetric and perinatal outcome. So this was a retrospective cohort study from Boston School of Medicine, where women more than 18 years with no known thyroid disease during prenatal period were included in the study, and fetuses and infant also were included. And the main outcome was risk ratios of adverse and obstetric and perinatal outcomes. So there were 8,400 pregnant women, of which 130, that is 1.6%, had a TSH more than 4. So they compared the women with TSH more than 4 with the women who had TSH less than 4. So maternal TSH more than 4 compared to TSH less than 4 was associated with increased risk of prematurity with a risk ratio of 2.17 and also with neonatal respiratory distress syndrome compared with the TSH level of less than 4. So therefore, maternal TSH concentration of more than 4 was associated with a twofold increased risk of prematurity and respiratory distress in offspring. Coming to thyroid and pediatrics. So nodule risk stratification systems such as the ACR tirads have altered the care of adults with thyroid nodules. However, it is not known whether tirads can be applied to nodules in the pediatric population. So in this study, which was published in Journal of Radiology, Richman et al. Assessed tirads retrospectively in a pediatric cohort. So thyroid nodules in patients less than 19 years who underwent FNAC, the ACR tirads was recreated to determine how the nodule would be managed. And it was used to determine if the ACR tirads would have changed the rates of FNA. So the 314 patients with 404 thyroid nodules were scored, and most of the cancers were papillary thyroid cancer. So the distribution of thyroid nodules according to ACR tirads is summarized in this table. So as you can see, the highest rates of malignancies were in the tirads 5 category with tirads 5 and 4 category, but around six patients, that is 7.7% of patients were classified as tirads 1 and 2. And this table shows the recommended management of nodules in this cohort based on the ACR tirads criteria. So among the 77 patients who had malignant nodules, 162 would have 60 would have undergone FNAC, 9 would have been on follow-up, but 8 patients would have not been on any follow-up or FNAC if the ACR tirads were applied in this population. So total of 19% of nodules were cancerous, and use of ACR tirads would have missed 17, that is 22% of cancers. So the use of current ACR tirads criteria for the management of pediatric thyroid nodules is inadequate because of a high percentage of cancers would be missed at the initial encounter. A major limitation was that this was a retrospective study. So coming to changes in thyroid function and across adolescents, a longitudinal study, almost all the published studies of thyroid function in adolescents are cross-sectional. And also a recent review found marked inconsistencies in reported reference ranges for thyroid function across the age groups. So the aims of this study were to examine longitudinal trends in TSH, FT3 and FT4 and determine 8 specific reference ranges. So thyroid function was assessed in 3,415 participants, and participants were enrolled from the Brisbane longitudinal twin study. Longitudinal analysis was adjusted for body mass index and puberty. So this figure shows the distribution of TSH, FT3 and FT4 for antibody negative participants at age 12, 14 and 16. So if you look at the bottom one, FT4, in girls, mean FT4 increased between the ages of 12 to 14. And from 14 to 16, in both boys and girls, there was a gradual downward trend in FT4, upward trend in FT4. FT3, there was a more marked increase in boys between 12 to 14 years when it was compared to girls. And then from 14 to 16, it decreased in both sexes. TSH more or less remained same during 12 to 14 period. But then after 14 years, there was a gradual increase in both males and females. So this graph, which is not visible, but it shows the reference ranges in comparison with adults and during the adolescent period. So it can, on the right side, it shows the percentage of patients who would be misclassified based on the adult cutoff. Almost all the classes, the patients would have been misclassified as normal or abnormal if the adult cutoffs were used. And the reference ranges differed substantially from adults, particularly for FT3 and FT4. So thyroid function tests in adolescents display complex sexually dimorphic patterns, and implementation of adolescent-specific ranges may be appropriate. So disparities in thyroid is an understudied yet important area of research in thyroidology. And majority of the disparities in thyroid research are conducted in either thyroid cancer or surgical population. There has been limited research in treatment of benign thyroid disease. So this is a cross-sectional study which was published, and socio-demographic disparities in the treatment of hypothyroidism. So this was a cross-sectional study from a representative sample of US patients more than 20 years with hypothyroidism, and patients were excluded if they had pregnancy or history of thyroid cancer. So patients were categorized as undertreated, overtreated, or adequately treated. When they did multivariate analysis, this showed that women were more likely than men to be taking thyroid hormones, as were older participants and also patients who had easy access to healthcare. In multivariate regression analysis, Hispanic ethnicity was associated with increased risk of inadequate treatment when compared to non-Hispanic whites. So clinicians should be aware of the socio-demographic disparities in the hypothyroid population and consider strategies to improve treatment of hypothyroidism in men, younger adults, Hispanics, and those without access to routine healthcare. In our scenario, the factors may change, but we should just be aware that there are certain disparities which can exist even in the treatment of hypothyroids. So thank you for your patient listening.
Thank you, Dr. Arjun, for discussing the recent articles during the last few years. So I was under the impression you were talking on thyroid disease in COVID pandemic. And a very nice selection of cases, selection of articles, and very good discussion. So I think they are open for discussion. And Dr. Anish will regulate the question answers.
Arjun, it was an elaborative talk, difficult to do things. So I think I have a doubt now. Your one paper says TSH during pregnancy, more than up to 10, you should not treat. And one paper showed between 4 to 10, you need to treat. So what is your recommendation?
The first paper showed that it was not a TSH more than 10, which we should not treat. It just showed that women who had at least one TSH value more than, when compared to one TSH value less than 0.1, the people who had TSH less than 1 had increased 0.1 had an increased risk of preterm delivery, whereas more than 10 did not have. I'm not saying don't treat, but we should be aware. The conclusion of that study would be we should be aware of the over treatment also rather than just the under treatment.
Thank you. Any more questions? So I think if there are no questions, thanks Surgeon for the wonderful talk. So with this, I'm concluding the session and handing over to the organizers.
Thank you.
Thank you, chairpersons and speakers. Now we are coming to the end of the last session. So the final talk will be on pediatric thyroidology, state of the art. I request the chairpersons, Dr. Ajish TP, who's the consultant endocrinologist at Travancore Medical College, Kollam, and Dr. Girish P, who's the consultant endocrinologist at Renai Medicity, to chair the session. Over to the chairpersons to take over the proceedings.
Thank you. So next session is on pediatric thyroidology, the state of art. So this will be dealt by Dr. Gina Susan George, who is a consultant endocrinologist, General Hospital, Ernakulam. She has done his DM from Government Medical College, Trivandrum, and has got an excellent academic career. Over to you, Dr. Gina.
Thank you, sir, for the kind words of introduction. So at the outset, I would like to thank the Amrita team for giving me this opportunity for a junior like me. So I've been asked to discuss on pediatric thyroidology, the recent advances and the state of the art. So as when Nisha ma'am called me, she told me that I should be dealing mainly with the two guidelines which came up in the field of congenital hypothyroidism and pediatric Graves. So in accordance with that, congenital hypothyroidism is the major disorder we come across. So that will be taking up the major chunk of the presentation, followed by pediatric Graves and certain miscellaneous topics. So we'll start with the case scenario. This was dealt by a pediatric endocrinologist from Trivandrum department. This was a 12-year-old female for which a consultation was sought for a TSH of more than 100, and the surgery was for bilateral ovarian tumor. So we thought that it may be multicystic ovaries due to uncontrolled hypothyroidism, and surgery was deferred, and she was started on supplementation. And on probing the history, she was diagnosed with hypothyroidism at 3 years of age. It was a known case of chorioathetoid cerebral palsy, and this was attributed to hypoxia which occurred in the perinatal period and which required mechanical ventilatory support. So connecting the dots that the child had hypothyroidism, a neurological abnormality, and respiratory condition, and the USG neck showed a small atrophic thyroid. A targeted genetic study was ordered, which came positive for NKX21. So this is an autosomal dominant condition, and is the most frequent transcription factor mutation thyroid dysgenesis. It's called the brain-lung thyroid syndrome. So coming to congenital hypothyroidism, it is defined as thyroid hormone deficiency, which is present at birth. It is the most common endocrine disorder in childhood, and is the most common cause for correctable neurological issues in childhood. And overall, the etiology can be divided as primary CH, secondary CH, peripheral CH, and transient CH. And thyroid dysgenesis is due to a structural abnormality in the thyroid, and it involves a spectrum of thyroidagenesis, hypoplasia, and ectopy, of which ectopic thyroid tissue is the most common one. It usually occurs sporadically, but in 2 to 5% cases, a genetic mutation can be attributed. So these are the clinical features which should help in ordering a targeted genetic study. There is IRDS and chorea is seen in NKX2-1 mutation, cleft palate, choanal atresia, spiky hair is seen in FOXC1 mutation. Urogenital malformations are seen in PAX8, and neonatal diabetes and hepatic fibrosis are seen in GLIS3 mutation. And there are several other mutations which are being associated with congenital heart disease also. So that brings us to the question, is screening for associated malformation needed? And the guidelines recommend so that cardiac side effects or cardiac malformation should be particularly sought for, and it occurs to a tune of 3 to 11% when compared to the normal live births. Hearing test also should be performed in all babies with congenital hypothyroidism, as thyroid hormone has a role in cochlear and auditory function development. And there are several other upcoming mutations, and it is an ever-expanding spectrum. Borealian mutation has been identified, which causes thyroid dysgenesis, and the TUB1 mutation, which is associated with thyroid dysgenesis and an abnormal platel physiology. Now coming to thyroid dyshomogenesis. The gland per se is normal, but there is some abnormality in the machinery which results in the thyroid hormone production, and it is associated with goiter. And it has a more genetic cause because it is inherited in an autosomal recessive manner. The culprit genes involved are the mutations in thyroglobin, the thyroid TPO, deox2 and deoxa2, pendrin, NIS, and dehydrogenase. And of particular interest recently is the Diox-2 and Dioxa-2, which was attributed to cause transient hypothyroidism. The issue with this is that the initial value may be borderline, but on confirmatory testing, the TSH levels may be high. So if the cutoffs for newborn screening are set at a lower level, we may miss such cases. And another thing which came up was that it was shown that Diox-2 and Dioxa-2, which is originally responsible for thyroid hormone dyshomogenesis, has been implicated in thyroid dysgenesis also, thus narrowing the gap between both of these conditions. And in those with thyroid dyshomogenesis, they require follow-up for development of goiter or thyroid nodules and slight increase in risk of malignancy. And it is mainly associated with mutations in TPO gene. And in such cases, TSH should be targeted to the lower part of normal, and they should be followed by periodical neck USG. Coming to central hypothyroidism, it is due to a defect in the hypothalamus or pituitary, and it can occur either isolated or as a part of multiple pituitary hormone deficiency. The clinical features are usually mild, and the goiter is usually absent. And these are the genes responsible for isolated CCH. Then coming to transient congenital hypothyroidism, the causes are iodine deficiency in the mother, or transfer of maternal blocking antibodies if the mother was having Graves, or fetal exposure to antithyroid drugs, and maternal and neonatal iodine exposure. This is particularly seen in preterm infants because their Wolff-Chaikoff mechanism is not particularly developed. So they are more prone for hypothyroidism. Then the congenital hepatic hemangioma due to increased expression of type 3 iodothyroid dehydrogenase. Now coming to the newborn screening, the rationale is clear-cut. After implementation of the newborn screen, there is a drastic improvement in the mean IQ of the children. And so all the guidelines do recommend that NBS should be done for every newborn. As a national program has not been yet implemented in India, but Kerala again can be proud of this. This was a comprehensive newborn screening program which was implemented under the name Shalabam, and it is funded by National Health Mission. And it has been there from 2018. Now coming to the screening methods, we have a primary TSH method, primary T4 method, and combined TSH and T4 method. Ideal one is combined TSH and T4, but it is fraught with limitations due to high cost. Then there is a primary T4, which can detect the primary and central congenital hypothyroidism. But the disadvantage is that it is insensitive to detect compensated primary hypothyroidism, and the false positives may be quite high, resulting in increased recall rate. So we have the primary TSH based newborn screening, which is the most sensitive and specific. One disadvantage is that there may be false positive due to hypothyroxemia with delayed TSH elevation. Now sampling, either the cord blood or postnatal day 3 to 5 sample should be used for screening for CH, either serum or filter paper thyroid hormone assay can be used. Now, so which one to select, whether the cord blood or the postnatal sample? For this, we should have an idea regarding the postnatal TSH surge, which happens 30 minutes after birth, and it peaks at around 24 hours, then starts settling down from 48 to 72 hours of after birth. So due to escape from the issues due to neonatal surge, the false positive rates are comparatively less. And so the recall rate is less, and this can be used in cases in which the child has to be discharged early. Whereas in postnatal sample, we can combine the screening of other associated conditions like congenital adrenal hyperplasia and phenylketonuria. The only disadvantage is that if done early, it may pick up the elevated TSH, the unresolved elevated TSH, and result in false positive test. And again, it needs a specific assay to detect the TSH from the dried blood film. Now coming to the diagnosis and criteria for treatment. So now it's clear that all newborn should be screened either from the heel prick or cord blood. And if TSH is less than 20, it's considered normal. If the TSH is more than 20 and it is frankly elevated, we should immediately consider starting treatment. And after taking a confirmatory sample, a value more than 40 should be followed up by a confirmatory venous sample after 72 hours of age. And if the values are between 20 to 40, we can wait till around 7 to 10 days, because whatever unresolved TSH surge is there, and if the mild elevation is due to that, we can give time for that to settle down. And after the confirmatory venous sample is taken, if the TSH is high with the normal T4, we can consider repeating the test 2 weeks after the initial test. And if it is still more than 10, we should consider treatment. Low T4, irrespective of the TSH level, mandates treatment as early as possible. And etiological diagnosis can also be done side by side. This is the flowchart as recommended by the guidelines. It has lesser number of ramification, more clear. You can focus on the central part, that is, if the TSH is between 6 to 20, there are 3 options. Either we can start treatment immediately, or we can wait for 2 weeks, or we can plan a definitive diagnosis approach, like either relying on imaging. Now, this was a study which was published in IJM, and the study was done in CMC Vellore, in which they have experience from screening around 1,64,000 newborns. So there they follow the values got from cord blood, and the cutoff they used was 25 rather than 20, which was mentioned in the ISPE guidelines. So they say that if at a cutoff of 25 was taken, it had a 99% sensitivity and 97% specificity. And a lower screen cutoff of 20 would have resulted in an additional 300 babies with no improvement in sensitivity. So there are certain strategies which need to be followed in special categories. That is, in preterm, low birth weight babies and in sick neonates, the screening should be repeated again at 10 to 14 days. That's what the guidelines recommend. And in Down syndrome and those with neonates who are ill, repeat and screening at the end of neonatal period. And in case of multiple births, even if the initial screening is normal, we should repeat the test after 10 to 14 days, particularly in same sex twins. So this is a graph showing the rise in TSH, T4 and T3 in comparison with normal newborns and those who are preterm. You can see that the TSH, T4 and T3 all are attenuated. So they came up with a study that what is the optimal timing for repeat newborn screening. The guideline says that you need to measure only at 2 weeks. But they in the study showed that what they did was that all newborns post 33 weeks were screened with the TSH level, the TSH T4 levels every week till term. And they found that just a single test at 2 weeks after delivery would miss a majority number of cases. Ideally, the screening should be continued till term is attained. Now, coming to the imaging techniques, it is techniques in congenital hypothyroidism. It is recommended to determine the etiology of CH at the time of diagnosis itself, because early diagnosis, precise diagnosis can give us an added advantage in counseling the patients, counseling the parents that on the requirement of lifelong treatment. And treatment should not be delayed for conducting thyroid gland imaging studies. We can use either radioiodine scanning or a UST, but ideally both of these tests complement each other, so we should use both. Knee X-ray can be done to assess the severity of intrauterine hypothyroidism. So this is the radionuclide uptake and scan. You can see absent uptake is seen in aplasia, TSH beta gene mutation, receptor inactivating mutation, and iodide trapping defects. And large gland with increased uptake is seen in dyshormonogenesis. Major pitfall is that if the scan is done after initiation of treatment, there may be a negative scan. Thyroid USG again, absent radionuclide uptake with an absent thyroid gland visualized on USG is suggestive of thyroid aplasia as seen in this figure. Then absent uptake with a normal size gland again may give clue to causes due to TSH beta gene mutation, dyshormonogenesis, and those due to passage of maternal thyroid blocking antibodies. And large gland is suggestive of dyshormonogenesis. And thyroglobin, serum thyroglobin levels also may aid in infants with absent uptake. So low serum thyroglobin levels suggest thyroid aplasia, and increased TG levels are seen the following condition. And in CH due to transplantal passage of material blocking antibodies, the same can be measured. Now coming to the treatment and monitoring of CH. So ideally the treatment should be started not later than 2 weeks after birth, and the tablet should be given along with breast milk, soaked and crushed in breast milk till up to 6 months, following which it can be crushed in water and given. And to ensure compliance, it is preferable to give the tablet at the same time every day. So this is a chart which gives us a clue on the initial dose of thyroxine. This is based on the FT4 levels. So if the FT4 level is less than 0.38 nanogram per deciliter, we should consider a starting dose of 10 to 15 microgram per kg. And if it is more than 0.77 nanogram per deciliter, we can start with 10 microgram per kilogram. And if FT4 is within the age-specific reference interval, the starting dose should be between 5 to 10. And monitoring, ideally the FT4 and TSH should be measured before or at least 4 hours after LT4 administration. And the interpretation should be based on age-specific reference interval. And our aim is to rapidly normalize T4 within a span of 2 weeks. And TSH may take time to recover as a part of pituitary resistance due to severe congenital hypothyroidism, but usually it settles before 1 year, 1 year. Now, the first follow-up after treatment initiation is at 1 to 2 weeks, and every 2 weeks till TSH is normalized. Then every 1 to 3 months till 12 months, every 2 to 4 months till 3 years, and every 3 to 6 months till growth is complete. And also that TSH levels have to be checked after 4 weeks if at all we are changing the dose or if there is an elevation of TSH. Now a word on the treatment and monitoring of central CH. It is mandatory that we have to rule out concomitant adrenal insufficiency before initiation of treatment. And in severe forms, the initial dose is 10 to 15 microgram per kg. And in milder forms, those can be 5 to 10 microgram per kg per day. And we should target for a serum free T4 level above the median value for the age-specific reference interval. Now, how can you assume, or are there any clues in which we can differentiate between permanent and transient hypothyroidism? If USG or nuclear scan shows an absent or ectopic gland, yes. And or if at any time during the first year of life, if the TSH rises above 20 due to undertreatment, this is also suggestive of permanent congenital hypothyroidism. And if permanent congenital hypothyroidism is not established, we need to reevaluate. So revaluation is classically taught to be done at 3 years of age, and this should be done particularly in those cases for which a treatment was initiated, such as in sick babies, preterms, those who had a Norman gland on imaging, and in mild dyshomogenesis. So how do we do it? The dose can be tapered either by 1/3 for 2 to 3 weeks, and the TSH, a rising trend in TSH can be checked, or we can stop thyroxine for a period of 4 weeks, and the definitive test can be done. And if TSH is more than 10, permanence is confirmed and treatment should be continued. And if serum T4 or free T4 and TSH remains normal, it is probably transient congenital hypothyroidism and treatment is no longer needed. But still, these children need to be kept under follow-up because it may recur during puberty and pregnancy. So what was classically taught was to reevaluate at 3 years of age. But can we consider reevaluation even before? This study says that it can be done at 6 months, particularly in cases with gland in situ, those with an absent family history, and if the dose requirement is low. And they have proposed certain cutoffs that if at 6 and 12 months, if the dose requirement is 3.2 and 2.5 microgram per kg, it may suggest transient hypothyroidism, and we may consider stopping the treatment. So these are the situations in which genetic counseling should be proposed, and genetic counseling should be aimed to improve the diagnosis, treatment, or prognosis. And but the benefits and limits of genetic testing should be discussed with parents and families. Now a word on fetal hypothyroidism. The indications are the serendipitous discovery of fetal goiter in a routine USG scan, or if there is a previous child with dyshomogenesis, because the recurrence rate can be up to 25%. Ultrasound scan can be done from 20 to 22 weeks to detect fetal thyroid disorders, and the perimeter and diameter of the gland is taken. And if at all intervention is planned, photosynthesis should be done. But this is usually not required. We get some idea from the thyroid, the fetal goiter and the context itself. And the treatment is intraamniotic T4 injection in euthyroid pregnant women with large fetal goiter that is associated with hydramnios and tracheal occlusion. And in hypothyroid pregnant women, we have to treat the woman only. And 10 microgram per kg is estimated for the fetal weight is given every 15 days. Now coming to certain other topics. So this was an open label phase 2 trial showing the efficacy of triac in congenital hypothyroidism due to MCT8 deficiency. So MCT8 deficiency causes the Allen-Dudley syndrome, which causes severe intellectual and motor disability and is characterized by chronic thyrotoxics with an elevated T3 level and a deterioration, body weight, tachycardia, and muscle wasting. So triac is basically a thyroid hormone analog, and entry into the brain does not require the MCT8 transporter. So you can see that after initiation of treatment, the T3 level came down, so as the heart rate and the body weight also improved. Now a word on autoimmune thyroiditis in childhood. Autoimmune thyroiditis is the most common cause of acquired hypothyroidism in children. This was a study which included 201 children under 18 years of age. And they said that 26% of children who were euthyroid at presentation developed hypothyroidism, whereas over 50% of those with subclinical hypothyroidism went on to require treatment. And even those who presented with overt hypothyroidism, for around 16% recovered with time. So we should keep that in mind. Now coming to the next topic, pediatric Graves' disease. It is very rare as compared to Graves' disease in adults. The incidence is around 5 in 1 lakh, and this is even rare before the prepubertal period. And as just like in adults, the treatment is medical management. PTU is not considered. Propylthiouracil is not considered. And the starting dose in case of dose titration approach is 0.5 to 0.3 milligram per kg for methimazole and 0.25 to 0.5 milligram per kg for carbimazole. And in severe cases, we can start at a higher dose. And if euthyroid or hypothyroid, we can reduce the dose by 25 to 50%, and we can increase the dose by 25% if persistently hyperthyroid. And we should adjust the dose based on thyroid hormone in the first 4 to 6 months. And beyond that, we need both TSH and thyroid hormone. And we can consider stopping the treatment if there is control on a minimal dose of methimazole or carbimazole. There is another approach, block and replace approach. As we have been classically taught, the side effects are more with this approach because the per body weight use of antithyroid drugs is more in this case. The starting dose is higher. And as FT4 and FT3 normalize, we should start treatment with thyroxine, which is according to the age and weight. And the LT4 level should be titrated every 4 to 6 weeks. Now, the treatment duration which they propose is 3 years. And in those with those who have the likelihood of remission is low, we can give up to 5 years. And these are the conditions in which you should consider an increased likelihood of remission. That is an older age, female sex, Caucasian ethnicity, or a small goiter size, and mild TFT values at the initiation, and a low TSS RAP criteria titer. And the longer the duration of treatment, the more chance for remission. And the antibody levels decline by a median of 90% after 3 years of antithyroid drugs. Usually the minor side effects are common, and of which the most common is cutaneous reaction, either pruritic rash and urticaria. The serious side effects are further rare, and side effects like agranulocytosis are very rare in pediatric Graves' disease patients. And most of the adverse effects usually occurs in the first 3 months. And it is higher in the side effects are more in younger children, and it is dose dependent also. And a word about remission and relapse, as the remission is directly proportional to the duration of treatment, and we can expect a remission of around 43% if the child is treated for up to 5 to 6 years. The rate of relapse is 20 to 30%, and the relapse usually occurs within the first 12 months. And it is preferable to avoid stopping treatment in relation to the key milestones of the child, that is while preparing for an exam also. So how should the patients be followed after stopping antithyroid drugs? In the first year, it should be done every 3 to 4 months, and the second year every 6 months, and annually thereafter. There is a risk of a relapse, but we should also keep in mind about the risk of autoimmune hypothyroidism. And evaluation of thyroid function is required when the child becomes, if the female child becomes pregnant also. Now, what are the indications for definitive surgery, definitive treatment? That is either surgery or radioiodine ablation. That is when the requirement of antithyroid drugs is large, and there are severe side effects related to antithyroid drugs. And if the child cannot report the ATD-related side effects properly, and there is a compliance issue, and if a prolonged therapy has not resulted in remission, and in case of relapse. So the definitive treatment is radioiodine, and the objective as in adults is complete thyroid ablation to prevent future relapse and future development of thyroid cancer. And it is preferably avoided in children less than 5 years. In 5 to 10 years, it can be considered. And the antithyroid drug should be stopped for 3 to 7 days prior to the procedure. Now, this was a study which dealt with the efficacy and side effects of radioactive iodine treatment in pediatric Graves' disease. This was a review, and they concluded that is a safe definitive treatment in pediatric Graves' disease also. Both short-term and long-term side effects are very rare, and they recommend a personalized management or personalized dose for the children in contrast to those what we do in adult population. That is 11 to 15 millibecquerel iodine 131 per gram of thyroid tissue is the optimal dose to attain hypothyroidism. And for thyroidectomy, it should be done at a high volume center, and total thyroidectomy is the operation of choice. There should be preoperative preparation with the antithyroid drugs, iodine and beta blocker if required, and preoperative treatment with vitamin D can reduce the risk for postoperative transient hypocalcemia, and levothyroxine should be started soon after thyroidectomy. And in pediatric Graves' orbitopathy, mild GO symptoms can be treated expectantly, and in moderate to severe active GO cases, it should be treated with IV corticosteroids. And in chronic inactive stable GO, we should go for cosmetic surgery, but mind you that the decompression surgery should be postponed until facial skull is fully grown. So the last portion, this was dealt by Dr. Arjun. This came in the Radiology Society of North America. So we know that ACR-TRADS is a recognized tool for the management of adult thyroid malignancy. So this was a study in which they compared the number of nodules that would be biopsied with FNAC based on ACR-TRADS, and this was compared with the total number of nodules biopsied with FNA, and whether this would, this was a retrospective study, and whether this would change the rate of FNA and the timely diagnosis of cancer. And 314 patients were taken, and 4 not for thyroid nodules were scored. And they say that the use of ACR-TRADS would have resulted in missing of 22% of the cancers. And so they advise some modifications also. That is, this is the ACR-TRADS in adults. These are the size cutoffs for which we should do FNAC. And they suggest that in pediatric age group, irrespective of the, in TRADS 1 and 2, irrespective of the TRADS 1 and 2, we should go for FNAC in all those nodules more than 4 centimeter. And in TRADS 3 for adults, the cutoff is 2.5, whereas in pediatrics, it should be brought down to 1.5 centimeter. And in TRADS 4, we do it a size of more than or equal to 1 centimeter. And TRADS 5 is the same, but it should be considered if the size is between 0.5 and 0.9 centimeter. So coming to the conclusion, the take home points, the major key points which should be kept in mind is that reevaluation of congenital hypothyroidism can be done before 6 months. It was classically taught as 3 years. Then medical management of pediatric graves can be continued up to 5 years. And size cutoffs for FNA in ACR triads may be inadequate in detecting thyroid malignancy in children. So these are the references, and thank you.
Thank you, Dr. Gina, for taking us through the latest updates in Graves' disease as well as congenital hypothyroidism, and also giving some insights about the need for better scoring system for thyroid nodules. As we are already short of time, we'll just take 1 or 2 quick questions before concluding the session and the program. Yes, Akare.
Thank you, Gina, for an excellent review on pediatric thyroidology. As you have already discussed, there is an increased risk of relapse, more than nearly 50% in Graves' disease. So in adults, they say that you can measure TSH receptor antibodies before stopping. Is there any such recommendation?
Yes, they follow the same criteria in pediatric Graves also. If the TSH RAPs are of low titer, it should be checked before stopping therapy.
So that would mandate checking TSH receptor before starting treatment, right?
Yes.
So definitely you'd want a TSH receptor antibody at the start of treatment as well as later on.
Prior to stopping.
Or if you have not checked it, if the receptors are undetectable, even then you can stop.
Yes.
Right?
Yes.
Dr. Gina, a small question. I request your insights as a pediatrician. The guidelines, I think the new European guidelines which you mentioned, the 6 to 20, they have specifically mentioned for healthy babies.
Yes.
Healthy babies.
Yes.
So what do you mean by this healthy babies? My confusion is always with regards to this preterm. In extreme preterm, agreed. What about those guys, those patients who had some brief ICU stay, coming out of it and all those stuff? So what is this healthy definition? What would be considered as a healthy baby? That 3 weeks thing. They've brought it down, no? They've brought it down to 6.
Yes.
6 to
21.
Healthy babies, you can treat. Or you may wait. That's
Yes,
what
we can wait.
We can wait or we may wait. Most of us would wait a bit, but it's a kind of strong statement. So what is this healthy, this thing? Pediatric insights, not...
Sir, I would like to ask the questions to pediatricians over here who have managed.
Again, I mean, the benefit should be given to the treatment part, sir. I mean, I go for the treatment and then wait. Even if the TSH is maybe borderline elevated, it's better to treat for at least 2-3 weeks, recheck the thyroid function test, and then take it from that time. Preterms?
Meaning there might be some 1 month preterm and all those stuff.
Okay.
They had some ICU stay for 10 days, just coming out of it.
In a good number of patients, those TSH will return back to normal. I mean, when you follow, because I mean, in personal experience, a good number of patients in that situation, I'll go with the T4 also. The T4 is above the 50% of normal, then definitely I'll wait for another 2 weeks and repeat the test.
Exactly the point. So T4 also matters, I think. So it's kind of very difficult to say 60 to 20 healthy.
Yeah.
So
Yes,
I think
true.
most of us do that.
Again, another question to add on to that. In some of the patients, when you treat with thyroxine, the T4 is always on the higher side of normal or above the upper limit of normal, but the TSH is around 6, 7. So you go by the T4 values or you go by the TSH values?
What the recommendation says is that if the TSH is in the normal range and FT4 is elevated, we need not decrease the dose of thyroxine. But a low TSH with a high FT4 mandates the decrease in the thyroxine dose.
High TSH with high T4?
High
TSH is 7 and on treatment. Pure congenital hypothyroidism, initial TSH is more than 40. You start treatment with thyroxine. The free T4 is high, like 1.5 times upper limit of normal, and the TSH is 6 or 7. Do you increase the dose or wait for?
A practical challenge we have faced is that usually the children take the tablet and then take the test. We should specifically advise them not to do so. On the day of testing, they should not take the tablet. And if TSH is elevated and FT4 is elevated, we should increase the dose to bring the TSH to the normal range.
Any take on that, sir? Any take on that? I mean,
but there is a concept of pituitary resistance. The TSH may take time to be normalized, and this may be there till around 1 to 3 years of age. So that should also be kept in mind.
I don't know whether it is evidence-based, because earlier pediatric endocrinologists used to titrate the T4 for at least 2 to 3 months and then focus on the TSH. I don't know whether it is right. I go by TSH alone.
Okay.
And the percentage of remission in congenital hypothyroidism, if the ultrasound neg is normal, how many percentage of congenital hypothyroidism can go in for remission?
If in remission has been described classically in those with thyroid dyshomogenesis, there are certain mutations which can cause transient hypothyroidism. And if follow up the patients, the dose requirement is less, as mentioned in this study. If it is less than 2.5, the requirement is less than 2.5 microgram per day, it may be, and initially it may be a transient hypothyroidism itself. So we may consider stopping. That may be a part of the disease per se. It might have been a transient hypothyroidism.
I think if there are no more questions, we can close the session.
Thank you, Ron.
Thank you, chairpersons and speaker, for the wonderful interactive session. So with this, we come to the end of the scientific session. Once again, I would like to thank all our speakers and chairpersons for their enlightening presentation and the excellent and the interactive discussion. Even though we have slightly overshot our time, I think we had a wonderful and a fruitful discussion with few take-home points. I would like to thank all the delegates who have come here on a holiday and who have accepted our invitation, and also would like to thank those who are present online. On behalf of AIIMS Department of Endocrinology, I would like to thank the ABOT team, Mr. Sandeep and the event management team, without whom the event would not have been successful. Last but not the least, I would like to thank Praveen sir and Nisha madam for their efforts in making this event a fruitful one. Thank you all once again. The lunch is served in the next hall. I request all the delegates and faculty to move on. Thank you. Sorry, can you all be back on the inside the hall? We'll wind up with the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे